Thank you, everybody, for moving in. You know, we are going to be trying, we've got a lot to get through this morning. We are going to try and keep to the time frame, and I know people have given up time in a very busy life to be here. So if you can move in, that'd be great. Just sit there and then I'll do the intro. Good morning. I would ask you to take your seats, and it's not bad. It's only 8:04, and you've got to love when you have a breakfast meeting and everybody gets together and starts chatting. It's always the same at morning tea and lunchtime, isn't it, at these forums? I'll just start first by thanking all of you for being here and welcoming you to today's Health Summit. This has been a journey and it continues, but the room is full of passionate and committed people. I'll start by acknowledging country. Wodonga Council acknowledges Aboriginal and Torres Strait Islander people as the first inhabitants of the country. We respect their ancestors, elders and young, and recognise their continuous connections to lands, waters and communities across the country. I'd also like to acknowledge all of you for taking the time to be here. It's a big commitment, but health professionals, academics, politicians, leaders of community and community members have really been working hard to get the best outcomes for this regional community. Just about me, my name's Leanne Barnes, and I've been asked to help guide and heard you all through the session today to get the best outcomes that we possibly can in terms of actioning collaboratively moving forward. I've got a long history in local government, so I'm used to dealing with councillors. That's probably one of the hardest group of politicians to herd, but I'm also on a local health district board, so I've had a huge learning curve in the last little while. This is my third visit here. I live in Merimbula, and I have to say, working with the councils and having had presentations from a number of the health people across the border, this is a remarkable community, and what a wonderful opportunity this is with a cross-border opportunity to take steps forward. And I'm actually honoured to be a part of this process to actually help you take the next steps. And this forum resulted from the last session we had of local government together in October last year. Was an outcome and action out of that meeting was to present to Wodonga City Council the opportunity to host a forum in February. Well, we missed it by a day, but we are there. And the 1st of March, having a forum, getting all the key players in the room together to start moving that forward. I'm just going to start by a little bit of the housekeeping that you have to do for the Cube. Now, if anything happens and there's an emergency, and who knows with the heat the way it's been, you know, something could happen, there will be a siren, and we exit through the exits, and there are staff from the Cube in here that will help guide us. We move across to the Hyphen, which is the cantilevered building across over here, so out and turn left and out the door. If you're needing to go to take a break, the toilets are out towards the front door and to the left, and we will be having a couple of breaks, but we will be on point to get people back in the room. The other thing I have to announce that this is being live streamed, so there's a camera up the top there, so that people that couldn't attend are able to see the progress of the discussions and hear the presentations today and work through that process. The room is set up in a quite interesting way because there was limited capacity, and so the people that are down on the floors, key organisations were given one representative, but there was no closing off. This is about being an open forum. So if anybody else from those organisations, those councils have attended, there's opportunities to participate and sit in the rake seating, and also members of the community. So I think that's a good balance in terms of being able to work that through. So I just will start by talking about the aim of today, which is to look at the strengths, look at what the challenges are in terms of addressing the future for the Albury Wodonga Health Service, particularly with the initiative and the development of a facility and funding that's come from the state and the two states and a bit from the federal government. There's many people to speak, and there will be time at the end of each of the panels for questions and answers, or making statements. And I do encourage you to think about those in terms of looking forward. How do we progress to next steps to get outcomes here? As I've said a couple of times, it's a short time, so we will be focusing on making sure that we move on time so that people can leave. And I'm encouraging you to think about next steps. Think about your questioning, thinking about the session that we'll have at the end, which will be an opportunity for all to participate, thinking about what are the things that we need together to work on to see this progress to the best outcome. So we have some time commitments, and there will be bells, but I'll get people back in on time. I'd also now like to, importantly, introduce the Wodonga Mayor, Councillor Ron Mildren, to deliver our opening address on the power of regional leadership in health advocacy.
Thank you. Given the time constraints, I'll try and be straight to the point. The power of regional leadership is a fairly big topic in association with what we're doing. So welcome to Wodonga and this vitally important summit on our regional health services and infrastructure. Welcome to our federal and state ministers and members of parliament, facilitators, speakers and panellists. Welcome to Border Medical Association, mayors, councillors, delegates and to those attending in the gallery and online. Today has the potential to be a landmark day for health services and infrastructure planning, not only in our region but as part of a national structure of health services and infrastructure. Today is the culmination of several years' health service advocacy, commencing well before the funding announcement. More significantly, today is the start of assertive regional leadership driving an advocacy agenda to achieve health service solutions to meet our regional needs and aspirations. Today we draw from the lessons learnt and draw from the knowledge of a well-credentialed and experienced room full of people associated with health service infrastructure. We have had confirmed through the release of Albury Wodonga Health correspondence to both the Victorian and New South Wales health ministers that, put in my simple terms, a single site facility cannot be delivered for the funds allocated and that the announced infrastructure cannot be delivered for the funds allocated. Sadly, this is no surprise to many of us. We already know that very significant external to the site works are required for utilities and accessibility for redevelopment of the current site, and that these works are not funded and can be expected to cost significant amounts. Being in New South Wales, it is unlikely that Victoria would contribute funding for work beyond the site that have broader benefit within the New South Wales neighbourhoods. Despite yesterday's revelations, the information generates more questions than answers, particularly in relation to the so-called master planning that was released yesterday, and casts increasing doubt that the, albeit now diluted, project will actually come to fruition, which may be a disguised benefit providing time to reset the planning and funding process. This will enable genuine regional advocacy and wider regional health professional input. We have over 300,000 people in our region, and consider this, just under 2/3 of that population is within the catchment outside of Albury and Wodonga municipalities. Truly decentralised region. Our region is one of, if not the fastest growing region, and based on average growth over the past 15 years, the next 10 years will see the order of 45 to 50,000 people added to our regional population. The growth of our region will see the gravitational pull progressively expand the regional sphere of influence generally, but particularly in health services. So as we grow, we impact a wider and wider region. The economic growth genie is out of the bottle in Albury Wodonga region. Whilst the state border continues to throw up inconveniences, the regional community is essentially one socially and economically. And that's important. And it's up to us as leaders in our respective fields to make sure health services and infrastructure get and remain ahead of our community needs and aspirations. Local government is required to advocate on behalf of its community and to undertake and participate in strategic health and wellbeing planning for its communities. In this context, that means coordinated and collegiate regional strategic health and wellbeing planning and advocacy across the region. If we don't stand up as a regional leadership for our communities, we will get what we are given from the remote state governments who aren't part of our community. Let me make this very clear. Today is not about whether or not a single site hospital is to be built in Albury or Wodonga, in New South Wales or Victoria. It is about achieving a readily accessible single site facility that delivers everything needed to address our regional health service needs and aspirations and to deliver our rightful place in the national hierarchy. That'll become obvious in a moment. In a political, bipartisan and an efficient and effective manner that takes advantage of our unique opportunities. And again, that'll become obvious. We can produce a solution that is a contributor to better health services over New South Wales and Victoria, not least through reduction in stresses created by escalation referrals to Melbourne, Sydney or Canberra hospitals, but also by making our regional facility conducive to the attraction of more and diverse specialist practices in Albury Wodonga. I call upon the regional military and tertiary leaders to actively pursue inclusion in the health service solution. We have a resource of military medics being educated here who would benefit enormously from real-life hands-on experience within the health service, and the health service is critically short of staff. This is where the Commonwealth Government can play a very critical role. We have 3 tertiary institutions that undertake health service education in Albury Wodonga that have capacity to increase numbers and types of service education. If the links to local health service could be strengthened and more formalised and appropriate infrastructure included to accommodate tertiary education within our health service infrastructure, within the planned development. Again, this will improve health service staff resource and is where the Commonwealth Government can play a critical role. The power of regional leadership can ensure that health service and infrastructure planning is a comprehensive exercise, inclusive of all aspects contributing to the need, aspirations, cost, effectiveness and efficiency. It is critically important that health service and infrastructure planning be undertaken in a comprehensive and integrated manner and not in a specialised or individual portfolio silo as it is today. It's important that the power of regional leadership be exercised in bringing the local knowledge across the board to the planning table. Things such as utility servicing, transport, accessibility, economies of scale, potential co-locationing, private facilities and specialist practices and local surrounding issues and land uses will all influence location, cost, effectiveness and efficiency. The power of regional leadership can ensure that the needs and aspirations of the regional economy or regional community are a legitimate part of health service and planning. It can ensure that outcomes are not imposed on the region from beyond the region. The power of regional leadership can be a very strong supportive resource for the Regional Health Service Board in health service and infrastructure planning and can ensure that planning is for the regional benefit rather than local objectives. The power of regional leadership can ensure that project planning processes undertaken by health authorities are done in the proper order, based upon needs and aspirations, and in true consideration of the circumstances and opportunities presented by the regional community. In short, determine the service and infrastructure needs and aspiration before the allocation of money or delineation of staging. Comprehensive strategic planning done first, then site selection, funding and staging thereafter. The power of regional leadership can encourage participation in health service and infrastructure planning and delivery by all levels of government, by all relevant government agencies and by relevant private sector participants and professionals across the health and allied health sector across all silos. If we as regional leaders leave health service and infrastructure planning entirely to governments and government agencies that are not intrinsically part of our regional community, then we will get what we are given. I'm sure you've heard that phrase over and over. And with increasingly less regional leadership advocacy, we will increasingly be given less. This is exacerbated by state border and by the tyranny of distance to the seats of power in Sydney and Melbourne. The population of Greater City of Geelong is about 275,000 plus about 40,000 in Surf Coast Shire, giving a regional population of about 315,000. We have a regional service catchment population of over 300,000 and on a percentage basis, Wodonga's growth has surpassed that of Geelong. Our more than 300,000 regional population is significantly greater than Hobart and on par with Wollongong. We should be exercising the regional leadership power that this population and a very high rate growth brings. Today is not about tit-for-tat arguments about history or the way things have proceeded to date. Today is about taking leadership responsibilities and creating a methodology, process and framework to achieve the integrated military and tertiary education included, high standard, high achieving health service and infrastructure which is the best outside of Melbourne and Sydney and which is conducive to attraction of higher order health professionals and specialists to our region. It's time we pulled our weight in the National Health Services and Infrastructure Framework. It is long overdue that we cast off the state border divisiveness and genuinely look to our region as a significant part of the National Health Service and Infrastructure Network. We should be building on the decentralisation legacies of former Federal Minister Tom Uren, the then two state governments and the Albury Wodonga Development Corporation, and asserting our rightful place in the national fabric. With the power of regional leadership of a growing 300,000 population, we can assert a right to commensurate genuine influence in health service and infrastructure planning. Today we have a wide range of professionals, political decision makers and learned people to produce a methodology, process and framework to achieve the highest standard of health service and infrastructure to meet our community needs and aspirations and to maximise the advantages of our local circumstances. The outcomes of today can be of national significance and influence and set a new template for regional health service and infrastructure delivery systems across Australia. It's time we truly diminish the vagaries and inconveniences of cross-border political and statistician anomalies impacting our single social and economic community. Government representatives, panellists, regional leadership delegates, today it's in your hands. Thank you very much.
Thank you, Ron. And as we all know, that is a really impassioned speech about the direction and the thoughts of a whole cross-section of the community that's here today. Thank you. I've heard Ron speak a number of times on this, and it really is something which is so close to his heart and I think reflects so much of what's in the room. I'd now like to introduce the CEO of the National Rural Health Alliance, Susie Teagan. And Susie will be working and presenting today on healthcare excellence as a catalyst for regional prosperity. And it's fabulous to have you here.
Thank you. Thank you very much. I'm going to put in context which one is it? There's a spark, so it must be that one. Oh, I'm not sure. How do you... Where's the forward? This is backwards.
I know. No, maybe that's that one. Yep.
Oh, here we go.
It's the big green one.
The big green, not the spark. I'm a Luddite. National Rural Health Alliance is a membership-based organisation which represents entities that either research from the day that they find a problem in a community all the way to the end of either commercialisation or policy development or funding proposals. We also look after those universities and training organisations that train the clinicians that work in rural, remote and regional Australia, and also those entities that deliver care in rural, remote and regional Australia. And they go along the whole value chain of the patient, the clinician and the researcher. The things that we do are in the areas that are really important because unless we have evidence and unless we have grassroots input, we're not able to influence either policy, funding or activities at the grassroots. The amount of people that we look after through our members are 7 million, so 30% of the population. And we look at workforce, innovative models of multidisciplinary care. We also look after those people that are developing policies from either the grassroots or on an industry-wide perspective. So it could be nursing, it could be medicines and the PBS. And we also have the Australian Journal of Rural Health. It's the only journal that only looks after rural, remote and regional health. And it's a way of distributing the information that we find from our research and also from our grassroots feedback. I've lived and worked in rural, remote and regional Australia for more than 30 years. And I have to say, in all those years, I think we've got to a situation where we're actually the worst off ever. I can see it in the clinicians, I can see it in the services that we provide, and I can see it in the population. 60% of our population, of the Aboriginal population, live in rural, remote and regional Australia, and closing the gap is not even close to meeting the targets. And We don't have a national rural health plan, so we can't even measure rural health, apart from having little bits of information about how our health is getting worse. The thing about it is that 30% of the population brings in one of the most impressive amounts of Australia's income. So 2/3 of Australia's exports are from rural, regional and remote. 90% of the food that everyone eats in Australia is from rural, regional and remote. And despite the fact that we are only 30% of the population, we bring in 50% of the tourism income. And yet, our expenditure on healthcare, whether it's federal or state, is well and truly below what the average person in the city receives. I've been on several Medicare review and reform committees, and I can see where the expenditure on Medicare is. The PBS, and I can tell you it's not here, despite the fact that the population is not doing as well. In 2023, we funded an independent report on the expenditure in rural, remote and regional health. The Alliance has been on the record since 2011 about the health funding deficit experienced by rural Australia. At the moment, per annum, there's a $6.55 billion underspend, and this is federal government funding only. That means about $848 per person less money. And you know, considering, let's say we're conservative and we have 300,000 people in this region, that you would have another 144 million per annum if you were to cash that in. If you were only considering 100,000 people and being even more conservative, it would be about 85 million. This data includes MBS, NDIS money, Medicare, Pharmacy Benefits Scheme, PBS, the Flying Doctors Service, because don't forget, the Flying Doctors is 50% funded by communities that have paid their taxes, they've paid their Medicare levy, they've contributed to the economy, and they're having to raise the funds. Could you imagine somebody in Wallara or in Toorak doing that? Oh, we don't have enough money for our services, so we're going to go and raise some money so we can access basic services. At some stage, this has to stop. The reason why we have a triple, possibly a quadruple disadvantage is that we have the social determinants of health, we have poor service availability, we have higher costs of access and delivery, and then of course we have more disasters and recoveries. And then we're told that we're going to be supported to be more resilient. We have a social contract to ensure that all Australians have equitable funds and equitable access to health services. When there are research studies done on Australian Disaster Resilience Index, Victoria and then New South Wales have the highest proportion of high resilience. Regional Australia Institute, an organisation we work very closely with, commissioned a market research to find out exactly how regional Australia was viewed by those living in our major metropolitan cities. They found that life in the region was top of mind for thousands of city dwellers. Over 2/3 of those considering moving here were ready to do so within a year. However, the concerns they had were about health, education and support with childcare. The top 3 factors driving people to leave the city were avoiding roads and traffic congestion, reducing general stress and anxiety, and reducing the cost of living. Of course, they also were very happy about the opportunities that were being provided for their children to have a better life. The Regional Australia Institute, with its members, including us, is an industry group that works across the Australian economy and society. It includes health, housing, employment, training, infrastructure, and we look at innovation, productivity, disaster resilience and transport. We have 20 targets addressing the fundamental aspects of regional living to ensure that people are able to live here well. On the way here, I was walking with two industry nurses that move around every 6 to 12 months from one community to another. And one of them was telling me that they were so well looked after, they're not going to go back to permanent work because not only was their pay really good, they were also given 1 day a week off to do some study. Why is it that we can't look after the people that are already on the ground? When HR 101 and also Sales 101 tells you that if you look after people in the first place, they will stay and will continue to come here and work with you. But if you don't, it actually costs you much more money to continue to have that revolving door. A key to regional prosperity is that prosperous rural communities are characterised by some very clear principles. And this is a study that's been done globally. It's the cultural aspect. So if you have a community of us and them, it's not going to work. The political components, where politics are politics, but you're still able to work in a bipartisan manner. Social life and the fabric that pulls everyone together. And where people have an entrepreneurial opportunity. Regional Victoria and New South Wales has had the largest increase in shop owners and in business owners in the last 3 years. And it has allowed for people to be entrepreneurial and to move away from the city. If you look at towns like Dunedin in New Zealand, about 10 years ago they had a competition, it may have even been longer than that, they had a competition to say which town around New Zealand should have the fastest internet. And Dunedin won. It has the fastest internet in Asia Pacific. And since then, it has brought so many startups and businesses, it has increased the capacity of the university and industry. We need to have one system where people work together. The average person doesn't care if you're state, federal or local. They don't care if you're an independent practitioner. They just want the system to work. Those people that work for the government or have received government funding, you're employed by the people. And in the end, you have a social contract to the community to do the best you can. We need to have a focus on population health, not on last year's budget. We need to have a focus on preventative health. There's plenty of talk about preventative health, but not much action. We have enough pilots. We have more pilots than Qantas. We're sick of it. We're sick of being the guinea pig of governments and other funders that no longer wish to put trust in those communities that already bring in billions of dollars. How much more do we need to give? In the end, these populations deserve more. They deserve more in education, they deserve more in health, And the discrepancy and inequity between city and rural has to stop, because what's happening now is that planning is going on historical funding. It's not going on an equitable distribution of funds. Thank you.
Thank you, Susie. Wow, I could go on and listen to those statistics and that framework and some of those ideas all day. So it's so hard trying to keep people into a time frame and catch up a little bit. As we move through to our next our next speaker, we're looking at the current local context. So would you please welcome the Chief Executive Officer of the Murray PHM Public Health Network, Matt Jones, who will focus on the importance of primary health care from very much a local perspective after we've had that fabulous introduction from Susie. Matt.
Sorry. Thank you very much for the invitation to come and speak today. I'd also... Thank you.
The green one.
The green one.
Big green one.
Thank you. I'd also like to express my pleasure in following Susie. I'd really like to commend the leadership and strong voice for the National Rural Health Alliance. So I'm really pleased to be able to speak today on the role of regional leadership and particularly health advocacy. I'd also like to acknowledge that we're meeting on Wiradjuri country and pay my respects to the elders, ancestors and young people, and also to all Aboriginal and Torres Strait Islander peoples. Just before I get into this, I think the topic of this session was around the importance of primary care and its reliance upon an acute system. So in the efforts to be hospitable to my hosts, I'd probably like to turn that completely on its head. I think we really, in order for us to really speak about regional leadership and health advocacy, I think perhaps we need to call it out, and I think we need to stop doing things particularly that aren't working. So in that spirit, I'd probably like to suggest that the acute system is incredibly important. The primary care system is incredibly important. The ability for people to be healthy in our communities is incredibly important. What's really important is that those parts come together, that play their respective roles. And I think we've got a real challenge in the way that we view healthcare. We focus on health in terms of hospitals. We view it in terms of hospital beds, hospital wards. People march in the streets associated with elective surgery and waiting lists and emergency departments. We need to talk about health in the community. We need to talk about how each of those parts play its role in keeping our communities healthy, and recognise that some of our focus is out of whack in order for our efforts to be able to achieve that. So let me start with how the Australian health system is structured. We spend about 10.5% of gross domestic product on healthcare. Comparatively, internationally, that places us in a pretty good order, particularly in relation to the health outcomes that it generates. But it works well for many people, but it doesn't necessarily work well for everybody in all instances. The way we have structured it, it's about 40% funding goes to hospitals, about 35% to primary care, and primary care is care in the community, general practice, pharmacy, allied health, etc. And the rest makes up about 25 million. About 2/3 of it comes from the Australian taxpayer, and then the rest comes from individual contributions and a range of other areas. In the primary care system, around that 35% represents about around 84 billion in 2021-22. That's primarily broken up into MBS, so Medicare Benefit Scheme of just on 17 billion, and Pharmaceutical Benefit Scheme around about 14-15 billion as well. There's increasing costs, as we know, and we've had the experience of COVID and the importance of primary care in terms of being able to provide vaccinations at a local level, but also the impact that that's had in terms of the provision of healthcare and the costs. But I really want to emphasise and point out the fact that 90% of Australians have been to see a GP or had a Medicare-based GP service at least once over the course of a 12-month period. So our reliance on the primary care system isn't just on its relationship with acute, it's actually about how it keeps people healthier in the community. Our health system is a combination of a number of things. It's based upon some really important principles and policies. Universal access to healthcare. The fact that when you're sick, you can go to a hospital. If you're unwell, you can go to a GP. That concept of universal access to healthcare is also supported by the fact that as Australian taxpayers, we contribute 2% each to Medicare. But the experience that we get in terms of what type of care we receive is very different according to our postcodes. And that's not recognised, that's not adequately accommodated, and as Susie so eloquently and strongly advocated, the need to recognise that we need different models in different contexts in order to enable universal access to healthcare effectively. It's also built on a range of really interesting and siloed dimensions, really structured and rigid elements. We have a federated health system. It's a combination of public and private funding from the Commonwealth and the state. It's also a mixed market approach where if it's profitable or sustainable, then it's available. And that then, between that federated and fragmented system actually produces what we get locally. And it's actually a misnomer to call it a health system. It's a collection of services that are co-located and the organisation coordination to enable that service to be more integrated, more coordinated, is much less than what we should expect from the health system. And importantly, there's some really important societal tidal changes that make that rigid system and make those structures really challenged in order to be responsive to the changes that we experience as a society. So that our costs, if we think of costs of healthcare, we've got this really perverse situation where increasingly people can't afford to access care, whilst simultaneously the costs of providing healthcare are unsustainable. Our care needs have changed incredibly. In the 40 years that Medicare was established, it was really geared around injury and illness. But now people are living with chronic disease for much longer. So instead of dying in the 60s of heart disease, lung disease, diabetes, etc., as we were 40 years ago, we're being diagnosed in our 40s and living until our 80s with those conditions. So our capacity to provide that responsive multidisciplinary care is challenged by the way in which we structure the financing and provision of healthcare. And culturally, we've got a very big changes that are occurring in the health system. The concept of someone moving to a small country town, buying the practice off the retiring GP, living there for 20, 30 years, providing all the in hours, after hours and emergency and procedural care to the local hospital, that concept not only is no longer fitting with aspirations for new graduates, but it's not financially viable. No one's going to buy a practice that's not financially viable and not offer the type of care that our communities need and lock themselves into arrangements that they won't be able to also meet their career aspirations. So we need to recognise that there's cultural change in the way in which people are wanting to participate in in providing a health care, their provision, their career, but also that we need structures to support that and enable the recruitment and retention and replenishment of healthcare locally. In terms of strain on the acute system, some pretty important elements that we need to understand is we've got a population of 26 million people. In 21-22 we had over 11 million hospitalisations. So that means either 40% of us have been hospitalised or many people are being admitted and on multiple occasions. And similarly in the emergency department, over 8 million emergency department presentations at our hospitals across Australia, which means there's a significant number of people that are representing to emergency departments because they can't access healthcare effectively. It's estimated that around 10% of all hospital admissions are potentially preventable. And that really speaks to the way in which we structure and provide healthcare and the access to healthcare to manage the chronic, acute and vaccine preventable conditions. And so a stronger focus on preventative health, a stronger focus on early disease detection and management and supporting in the community is a particular way to reduce that burden on the acute system. One area that has become quite prominent in thinking both at the federal and state levels is the need for emergency diversions into community settings. And here in Albury Wodonga, we've got the wonderful example of how the federated system is operating. We've got an urgent care clinic in Albury funded by the Commonwealth Health Department, supporting primary care provision. GPs working in the local community, diverting patients from the emergency department to services and funded specifically to do so. And the same concept in Victoria known as priority primary care clinics, in which we have one here in Wodonga. Very similarly focused, slightly different structured, slightly different in terms of funding, up to the community to try and navigate your way between what's an urgent care centre, what's a priority primary care clinic and how they relate to the emergency department and general practice. So these are important developments in terms of saying we're feeling pressure in the emergency department and that should be supported in primary care, but we do that in ways that make it very difficult for people to be able to navigate, very challenged for the health system to be able to provide that in an integrated, coordinated way, and the preferences and predilections of the state and federal governments mean that that's not often done in a coordinated, organised way. In the interest of time, I'll move through this one, but it's really around the concept of how the urgent care clinic is providing, or the priority primary care clinics are providing that service. If you've got a urgent but non-life-threatening service, then you're able to go to a local service and provide that care. And between these two services, in Wodonga and Albury, they're going to see around about 30,000 episodes of care over the course of a 12-month period when they're operating in full flight. So really important, and it's very much a service approach, because not every community can have an urgent care centre, not every community can have a priority primary care clinic, but in communities we expect to be able to see a doctor, we expect to be able to go and see a GP, we expect that we shouldn't have to wait long periods of time to be able to get in, and that the care matches our needs. And so how we structure and how we enable healthcare is really challenged by our current thinking, our current approaches that are about services and not looking at the way in which services are provided at the community level. We focus really strongly on acute services. We think that that's where the attention needs to go. As we've seen with how we fund it, it's less than half of the total health expenditure. Yet our attention is really down that downstream end. We need to be focusing not only on a better primary care system that's available locally, and we need to make sure that we've got the range of multidisciplinary care that we need. And as Susie has spoken about, we've got huge allied health deserts across regional Australia. Our health system works particularly well where you've got large populations in close proximity with economic capacity. But that doesn't describe much of regional Australia. And once you start changing those conditions, our capacity to access quality and effective healthcare is really challenged. And so we need to look at different models in different contexts in regards to suburban, urban, peri-urban, regional, rural and remote. And we need to replicate the way in which the way in which our health system's provided, in the way in which the community access that. People don't go to the hospital thinking this is a Victorian government funded or a New South Wales government service. They don't go to a general practice and think that this is a Commonwealth funded service, or the pharmacist and think that that's being provided through Commonwealth funding through PBS. It's your local GP, it's your local pharmacy, it's the local hospital. And they need to be more integrated and coordinated at a regional level. And we need to be advocating and encouraging how they not only are responsive to local needs and how they can be structured to deliver that, but how they integrate so that we've got emergency departments for for life-threatening conditions. We've got urgent care clinics for urgent needs. We've got general practice and pharmacy for the management of our care needs. And we've also got a local context where health and wellbeing is a really strong focus of the community, and we're managing to support people in terms of more effective nutrition, physical activity, and the built environment that encourages people to be healthy and enable healthy choices. And so our focus on not only health being hospitals, but hospitals being supported by primary care, and health being in a context of community where health is also connected to education, welfare, justice, employment, the physical and built environment. As community members, we should be seeing our needs in that context and encouraging our politicians and encouraging our funders and policy makers to see the need to have regional responses supporting the coordination and integration of care locally. So I think one of the real challenges is that we break things up and we think of we need workforce as a solution. We don't have enough GPs. And interestingly and importantly, in terms of those cultural changes, around about 25 years ago, between 40 and 50% of all medical graduates were choosing general practice as a career path. We started to hit real significant shortages in GPs in around about 15 years ago. We doubled the number of clinical places at schools. The solution was, all right, we need more GPs, we'll increase the number of people going through medical school to become doctors. Whilst we've increased the number of clinical places at teaching hospitals, at universities for medical graduates, the number of graduates choosing general practice has now dropped to 13%. So people aren't choosing that and there's a reason why, and partially it's not just how they work, it's not just that career choice, it's how they're working, where they're working, what it offers and how we can support that. So I think those leadership approaches at a regional level about building models, innovative approaches according to the needs of our communities and for communities to be engaged and advocating for the type of care that they require is the type of messages that we need to be communicating. We need to build that regional leadership, that advocacy for the type of care that we require locally and encourage collectively how the integration of the Australian healthcare system that is so fragmented, that is not meeting our needs, can be coordinated and organised at our local, regional and community level. Thanks very much.
Fabulous, and thank you so much, Matt. I think we've taken it from that big picture that Susie really talked about in terms of catalysing the regional prosperity in that health excellence down into more the bridging the gaps for future wellbeing. And now's the time to really get down into what's happening on the ground here in a border community. So I'd like to thank Matt and welcome Dr. David Clancy from the Border Medical Association for a practitioners on the ground review. And here's a little, there you go. And it's got a big instruction manual. No, it hasn't. It's got a big green arrow.
I've achieved my first objective for the day by not tripping on the stairs. I won't stand on ceremony and go through all the dignitaries, but thank you to everybody for being here. It does mean a lot. And thank you to Ron and your council and your team for getting this today. It is very impressive. There was meant to be a slide before that, I'm sorry, but the first slide is actually just a blank canvas. I spent forever trying to think of what would be the title for this. And I couldn't come up with one. I just stared at the screen. And then I just loved that there was a blank canvas that actually said, there's an opportunity. We've got an opportunity here to redraft what we do and how we do it. And that's the opportunity, and that's what I want to be able to represent. Don't want to just be putting on passion and anger. We've got an opportunity here. Now, I will say the other challenge to the talk was keeping it to time. Most people know that I do rabbit on. I am a Clancy. But I seek your forgiveness rather than your permission per se. I have done my best, but if you shake the magic 8 ball on my head about whether it's going to get to 25 minutes, the prognosis looks bleak. But if you shake it again, it'll say it'll be worth it. So, BMA, you can read about it. I would just challenge one part of that blurb there. We don't advocate for doctors, we advocate for our patients in our community. And people have asked us to talk about what's happening on the ground, the clinician's experience at AWH. And I don't really want to talk about that because I believe in AWH and I believe in the people there, and I don't want people not believing in them. What I want to tell you about is our experience advocating, because what I can show you is the barriers and the problems that we need to collectively solve. The games that get played, they're for sporting fields, not for health. Susie, loved your talk about investment in regional healthcare. And what do we value? Because to paraphrase what you're talking about is, we can't all live in a yellow cake submarine. We've really got to invest in what we value, and that's people, not submarines. Just a couple of acknowledgements. There are people that have fought for this because it's their job. But I want to thank the people that do this because it's not their job. Barb and Phil, there's not enough words. And to the people at Better Border Health, that motley crew, you may cop criticism. We mightn't always agree on the approach or the message, but you believed when no one else would, and you continued to believe when everyone thought the job was done. And all the people in the room and all the people out there, we all love to be the hero, and we all think that we did something as an individual, but nothing got done until the community got together. So Mr. Park asked, why do we continue to fight and why do we speak? Well, there is an element of benefit versus risk. We are aware of that. People might be expecting me to throw a few people under the bus today. I won't. There's too much risk in that, and it gives me no benefit right now. You'll have to wait to buy the book at the recommended retail price. We're just speaking up for safety. People talk about it. But outside of the clinical world, we don't practice it. Do you really hear what's going on? If somebody is dying in front of you and you're resuscitating them and you've got a team and no one speaks up when they see a problem, bad things happen and you don't get a second chance. The escalation pathways don't exist because you can do it within your organisation and everyone can understand, but it doesn't translate anywhere else. And here's the paradox. We're damned if we don't speak up. If we don't speak up for a patient in a hospital and an outcome happens, the coroner will ask you why. So if you want that, then you've got to accept that we have to speak up. We just want to give what our community needs. These are our people. It's our patients. We belong here. And there's so many rich opportunities. Believe me, this place can do so many things. Personally, it is about integrity. I have to look myself in the mirror and know that I've given everything I've got. There was a man that I knew who led by example and would never make somebody stand up and do something that he wasn't prepared to do. That same man taught his 16-year-old son when he was going to boarding school about privilege. He taught him, always look after the kid below you. He'll always remember that simple thing. The kid above you won't remember you. I need to honour that message. I have privilege. I'm a white, Anglo-Saxon straight male. I live with stress, but not hardship. I am obligated to speak for those that can't. And if I don't, there are close friends that will tell me otherwise. The theme is expectations versus outcomes. It's a simple equation. If the expectation is not met with an outcome, there's a massive gap. That can be disappointing. But if that happens time and time again, that disappointment can lead to being disillusioned, can lead to anger. But worse still, people become helpless. They become hopeless. Then they become apathetic. In health, apathy damages patients. When you set your expectations, be real. We all know the SMART goals: specific, measurable, realistic. We believe our expectations meet that criteria. I've told you why I'm here, but I want to know why you're here. I want to be able to look around the room and meet people's eyes and know. If I want you to understand me, I need to understand you. Why are you here? Are you here because you want to help? Are you here because you want to make a difference? Or are you here just to report back to the office? Or to make sure that you're not embarrassed by not being in the room? What are your expectations? Make sure your expectations are divorced of the bias, the parochialism. Get rid of the blinkers. Leave the ego at the door. If I'm prepared to be vulnerable to you, be vulnerable in return. Lovely line by Mark Twain. If you stick to what you know, we won't get anywhere. So what have been our expectations? It's about a cross-border health service. Our expectation is that we be recognised for our regional significance. Our expectations are about governance, consistency, transparency, and some bloody accountability. Our expectations are about the resources we need to do our job, to help our patients. And that's the infrastructure. Our expectations are we get back to trying to fulfil the 2021 Clinical Services Plan. It set out what we need. You can talk about greenfield or brownfield. That's how we do it. Once you understand what we need, that answer becomes self-evident. Susie spoke about healthcare in Australia. What's different here? A lot. We mentioned Mark Twain. There's the scruffy-looking fellow. And there's this beautiful story of when he came on the train in the 19th century, the longest railway platform in the Southern Hemisphere, because you had to change because of the different railway gauge. Couldn't believe it. Got a very long-winded way of saying, what the bloody hell were you thinking? But look at that last line. Think of the paralysis of intellect that gave that idea birth. Imagine the boulder it emerged from on some petrified legislator's shoulders. Marky Mark should have got off the train and had a look at the healthcare system. It's fragmentation, it's duplication, that it was ignored. They're in the 21st century now, people. That's what Albury Wodonga Health is. We love our river. Take it out of play. Took a long time to fight for it. Susan Lee can tell you about the fight for a freeway. Takes a long time. What if there was no state border there? You are smack bang, not just in the middle of 300,000, but you can go out to 500,000 once you go past Wagga and Shepparton. It could be the regional solution for regional people. The expectations were set when Albury Wodonga Health was created. The economies of scale, that we could be finally recognised and not ignored as being at the arse end of both states. The roles and responsibilities we expected to be delineated. You'd expect some change management, getting your IT right, getting your PAS right, getting your data flows right. And it was exciting. What's the outcome? and were still ignored. It was the drunken one-night stand where no one wants the baby. There's a lack of accountability. But what it manages to get done for this community, despite that, that's magic. Because it's sustained by the people there. As a friend said, it's held together with sticky tape and goodwill. The outcome is that we get ad hoc piecemeal funding, and we have to be happy with the scraps off the table. An ED funded in 2017 is still not commissioned, but it wasn't planned for a single site. A cath lab, welcomely received, but no one thinking about how we operationally fund it. The result of being ignored is you need to rely on noise. And people have got short memories. The late, brilliant surgeon Neil Bright wrote about this. His pride of coming to a community of clinicians that stood for excellence. He could see that people would blame a cross-border health service as the problem, not the neglect. He knew that if we didn't get this right, we can try and recruit all we can, you still can't do your job. And look at this. It's an opportunity. It's an opportunity to show what can be done. But it also can be a disaster if you don't get rid of the bias. More rallies, more articles. The outcome is we're still not understood. Our regional size and scale, our leadership, and we're actually losing ground. We talk about this Hume region model, where Goulburn Valley is to subsume the leadership because we are seen as Albury and Wodonga, not Albury Wodonga. The experience during COVID of the New South Wales model, diabolical, that we are seen still to be beneath Wagga. Our cardiac services, the New South Wales Ministry still directs New South Wales ambulances to pick up people in the northern half of Albury and drive them to Wagga if they know they're having a heart attack, when we have a cath lab that if you funded it, we could do it within 15 minutes. So the current state, the outcome. Barwon is a metro centre. We are the largest regional service in Victoria. You can look at the numbers. The activity climbs, but it's constrained in overwhelmed infrastructure. You can look at numbers of emergency presentations and how it compares to the cities. But you can't get the feel and the sense of panic of the emergency physician as she hears over the overhead, Cat 2 waiting room. The elective surgery, you can see the numbers. Waiting list greater than the Alfred. Do you know how big the Alfred is? But that doesn't tell you the unmet demand because of the GP that goes, we just need to send you elsewhere for your surgery because they know they can't get them done. It's overwhelming. No capacity. Minus 60 beds. Easy. Probably undercounting. 2 sites running between, trying to keep people going, spinning the plates. Infrastructure that is overwhelmed and not fit for purpose. An IT system that used to power a Commodore 64. And the moral injury that climbs on staff. Can you call it risk to patients when it's actually real outcomes? We had hope. We got change in leadership in 2019. A new man, a new leader. Sorry for the formatting. He recognised that, yeah, noise is good. Keep making the noise, but we need a process. He got the clinicians in. He created a structure, not a hierarchy. There's a difference. A structure creates scaffolding for getting a job done. A hierarchy squeezes it down. Get a coherent plan and put it forward. Work with us and trust the process. Trust the process. That's what we were asked to do. We did. We bought in. Beautiful documents. Clinical Services Plan 2021, Master Plan 2021. We are so proud of that work. It worked. That document is brilliant. Do you know why? It involved the subject matter experts. You can get your data. but put it in front of the people that know the business. They'll tell you what it means. It called out the current risks of 2 sites, the capacity, talked about the future needs, the opportunities, and the leadership that we provide. It called for a single-site hospital, called for providing care for our people closer to home. Don't worry about having to travel 5 kilometres to a hospital when right now you're having to travel 400. And the leadership, bring in other people, co-locate yourself with a private, recognise the importance of education, invest in it. And I'm here to tell you, you can listen to the departments and the ministers. The bed numbers in the theatres were validated. They were stress tested by the departments. The same people in that plan from the departments, every step of the way, were also in the master planning process. We used the numbers from the service plan for the master plan out to 2040. They were in the room. We had hope from a regional deal. Great opportunity, lifetime opportunity. Get the feds involved. Outcome? You tell me why. The 2021 master plan, a lot of fanfare, funded by New South Wales. Both states at the table, maybe not happy to be so. Clinicians, again, involved not just in the consultation, but the decision-making. 80,000 square metres were planned. Look at the glossy that dropped yesterday. Embarrassing. The greenfield was selected as the preferred outcome and to be used as all future planning. Why? Yep, there was critical growth. Yes, it would take time, but there could be interim solutions. But think of the difficulty of trying to provide the growth that we need right now, plus for our future, plus future-proof, plus co-locate, when all infrastructure is overwhelmed and obsolete. What do you prioritise? Get it done. Build it once, build it right. Anybody. I sat in the Pleasant Hills pub after the Hendy Field Days in September last year. Spoke to somebody from Coffs Harbour. Straight away, it passes the pub test. So our expectations, eyes were peeled. We're not naive, but we're engaged and united. The departments were along for the ride, maybe not willingly. We're ready to roll. New South Wales Premier came down, sat in an office with the CEO and chair of the board and said, "Gentlemen, you need a new hospital and I don't care which side of the river." Once again, Wagga stuffed it up for us. The outcome? Silence. 2022, where's the plan? It was getting revised. Why'd you need to revise it when you'd been at the table all along? Come on. Expectations, oh, this is not good. And the outcome? A big haircut to the projections and the planning. And a game of ducks and drakes with the master plan, not to be released. Revision of timings, costings and stagings. And then you get a great day. Again, sorry about how the formatting's come out. We get a commitment to a single-site hospital, a new single-site hospital. But the devil's in the detail. We're only throwing in 225 each. There is no further commitment to the stages to complete the job. That's not what happened in 2011 when the Wagga Brownfield was announced. There was a commitment to all stages. The expectation straight away is that this is not enough to cover our current needs, to deliver the growth, co-locate and decant in order to provide your next steps. It's never going to be done in one hit, but you've got to be prepared to invest in that first phase to get your next steps if you want a brownfield to work. Some of the Freudian slips that came out at that day. The previous chair of the board, yeah, we should have gone for a greenfield. The Premier of Victoria, the master plans for Albury Wodonga Health to release. That's not what was actually holding it back. And Dom Perrottet saying that it was based on the advice from health. Yeah. But what's the advice being given? Thank you to Amanda Conn for the documents that you've found and for the documents provided. Look at this. It's going to take some time, so bear with me. The idea highlighted here is that the brownfield at the top of the screen would be completed before a greenfield. Just compare the pair though, those stages and the bed numbers provided. Do they add up to that? Can you actually read that? Probably not. Answer's no. Trust me, I'm a doctor. Why so long for a greenfield? Yeah, we're not stupid. We actually know you've got to get the land, you've got to get planning permissions, we've got to invest in the utilities, the sewage, the electricity, the roads. Let's look what was underneath that last bit. That last 3 years is a slide dedicated to the decommissioning of your old hospital. You're actually in by 2028 if you'd started in 2022. That's the advice given to ministers, premiers. You can't blame them. Have a look at this beauty, a briefing to a treasurer who wouldn't understand Albury Wodonga Health. Again, thanks to Amanda. Your option one about your greenfield includes putting a few things into the kitty that aren't paid for by states, universities, accommodations. Option two takes out and says that the cost will be lower. Actually, no, that costing already excluded the ED and the mental health. Read the fine print. And this beauty, wasn't this a doozy? A briefing to a treasurer who does not understand the operational model of Albury Wodonga Health that says, we don't want to build a greenfield in Albury because we won't have the operational control. How is a treasurer to know that they don't have operational control now? That's Victorian run. What are you telling your ministers? That's not a master plan. This is a master plan. Let's give a glossy brochure, 2023. But there's a few things coming off the rails. The red flags that were coming. The change in the language from the ministers. Redevelopment, not new hospital, redevelopment. The concept of a Wodonga entity plan, unheard of. Use service plan for a health service, not for a building. Services being split before we even got going. Theatres, back to being across campus. The information that we received from the briefings that New South Wales Health Infrastructure gave the Border Medical Association, they told us that clinical services plan that got cut back in 2022 is getting cut back again. And at the same time, we're not projecting out to 2036 or 2040. We're now coming to a 10-year projection. But when we say we're going for a 10-year projection, we're saying out until 2032. Long time since I did maths. That's not 10 years. We've gone from planning for 80,000 square metres to building something that is 36,000 square metres. And watch that come down again. And our total plan till 2032, that is our hospital, will be 55,000 square metres. Some of the documents that Amanda has got out shows how they cut down the projections, not just what will be built, but the projections. And one of the silly numbers there is the ICU. I know it well. It's currently 12 beds with a couple over in Wodonga to provide support. And you want to give us 8. The amount of fighting and screaming we had to give to get that changed. Sorry for the business of the slide, but the briefing's continued. Just remember, your projections is not necessarily what will be delivered in a building. We're now back to maintaining old infrastructure and having to integrate all through that. The growth will cover our current deficits, getting out of those spaces that we've had to flow into the cancer centre and into an overflow unit. And we'll move the acute beds from Wodonga. That's about it. The theatre growth, 3 more theatres. We can't recruit surgeons at the moment because we don't have a theatre to put them in. Areas would be reduced. We've just built a cath lab in 2018 and we'll rebuild it. The one built in 2018 had space for a second cath lab. The new one won't. And you're rebuilding things like the kids' ward, maternity, ICU, the same size. There will not be significant decanting for your next stages to be easy. Yes, there'll be potential for next stages, but they're not easy. Get it right from the start, make your next stages easy. And still no messaging on what the staging are. 2023, that irrepressible force, Amanda Conn, she gets some of the documents out there, and there'll be more to come. So let's go to now. Fantastic to see a master plan released a day before a forum that might be a little bit politically precious. And the community consultation documents that exclude the concerns that were raised and just criticises those that are raising concerns. The outcomes continue to be short of expectations. As one senior clinician has said, this is not even close to being a minimum viable product. What's next to fall off? The facilitation of staging, the covering of clinical risk as we go. You can keep building buildings. Are you shifting the needle on the clinical outcomes? Stop telling me as an architect, as an engineer, because I'm telling you as a clinician. When do we shift the needle for our people? What's the end product? That's the point. You can talk about staging, but when do you get to your end product and is it sufficient? It's not too late. Let's move forward. The answer can't be just about making noise, guys. Something really needs to change here. I've got things that I can put on the table, but I want to hear from you as well. Let's not lose what is hard won. The problem is not Albury Wodonga Health. The problem is not being a cross-border solution. The problem is that we don't look to the solutions because we think they're too hard. Yes, they're complex. Complex does not need to be hard. Stop making it harder than it is. Stop the games. Let's get the governance right. Who's keeping an eye on the kids in the sandpit fighting over the toy? Can you expect 2 people to actually sort this out? Let's look to the opportunities and not the barriers. We can do wonderful things. Our expectation is we get back to what was documented in the Clinical Services Plan in 2021. The subsequent revisions kept the clinicians out of the room. You can get statistics, but are they facts? We still need, whether you want to do a brownfield or a greenfield, we need immediate capacity relief. We do. We've said that repeatedly. When you go to build it, whether you want to do brownfield or greenfield, do it once and do it right. Keep it simple. Okay? I have my biases. They may be considered biases, but they're actually based on facts and based on what we've seen. I'm happy to talk to you. I'm happy to sit at the table. But come sit at the table and let's talk it out. Get it done and we'll take care of the rest. Here's Neil. He died in 2018. I don't need to use his words again because I'll just use my own. Let's do better. Let's be better. There was meant to be a blank canvas. Picture the blank canvas. Get involved. Do your job so that we can just get back to doing ours. Thanks.
Thank you, David. And you were right, there definitely is a book in that. But let me tell you, the history presented there gives a very good setting for the rest of today's session, I think. And you covered an enormous amount of detail, but I think it was important to set that framework. So thank you. Now I'd like to welcome Susie back as the facilitator of the first panel for today, Catalysing Change, Collaborative Insights for Place-Based Health Care. And joining her are Professor Jane Mills, the Pro-Vice-Chancellor, Health Innovation Regional and Dean at the La Trobe Rural Health School, Dr. Philip Steele, Director of Border Regional Training Hub, Albury Rural Clinical Campus of the School of Clinical Medicine at the University of Melbourne, University of New South Wales Medicine and Health, and the CEO of the Rural Doctors Association of Australia, Peter Rutherford. So while we're just getting that, talk amongst yourselves while we're getting that set up.
I think this is on. Another one? This one doesn't.
Is there a... I'll turn this one off, but is it?
Can you hear me?
No.
You can?
Can
Can you hear me? Yes?
Yes, beautiful.
Fantastic. So we've got Professor Jane Mills, Peter Rutherford and Dr. Philip Steele. The first question I'm going to ask you, what were your first thoughts about the last three speakers, about the content of what was in their presentations?
I'll start. So I'm Peter Rutherford. I'm the CEO of the Rural Doctors Association of Australia, based in Canberra. I grew up in Albury Wodonga, so I get it. I get that you don't live in one town, you live in both. I was on the Wodonga side, so I also get the politics of Albury versus Wodonga. But I guess the frustration, and it does take time. Any change within government, all the advocacy, it takes perseverance, it takes time. There's a lot of saying the same message twice, 3 times, 4 times, and over many years. So the regional leadership is essential, but the persistence is absolutely critical. But I understand the frustrations, but it is about coming together as a community and finding your champions. Organisations like ours, like the Alliance, bringing them in, using their influence and their advocacy where you can, and things like that. But yeah, I hear it, I'm passionate about it because I know what the issues are, I understand the impacts, and I feel for the team that have really pushed and the frustration. I've also been involved in trying to get new hospitals built when I worked for Queensland Health in Kingaroy, and we got one. But again, we had multiple plans of a pile about this high that we would present because they kept doing planning and planning. So again, the frustration is real, I hear it, and we need to do better, I agree.
Jane? Thank you.
Thanks, Susie. I think the takeaway really from it was around new and contemporary models of care and actually trying to move away in a way, thinking, I suppose, about the broader picture around the provision of healthcare. I think Matt made some really great points there around the integration of primary and acute care services and actually trying to sort of get away from the idea of the built environment being a solution to healthcare services in regional areas, because it's only one small part of the picture. Although I take Peter's point, and obviously there's a lot of frustration there around the chopping and changing in terms of government and planning around the hospital environment, but really health is much more than that. So it's thinking about that question of integration and the role of universities in particular and primary care services, general practice, and ensuring that there's adequate funding to actually slow down the number of people who are landing in an acute care environment.
We'll get back to the education and also the preventative part of the health sector after. Philip?
Yeah, well, I guess as an insider, I probably come at this from a slightly different perspective from the other two, but very much see and understand the perspectives, like the broader perspectives that Matt certainly was talking about, and Susie was talking about in terms of rural health, rural and regional health nationally. It's as a GP by trade, and I've been here for a long time now. I have seen many changes in the health of the community over the years, and the increasing challenges of providing that care. It's so important to get the primary health care right, and I totally agree with Matt about that, but we still need an acute health service to provide that acute care, not just for our community here, but for our whole region. And I've been able to, over this period of time that I've been here, be able to really watch the development of Albury Wodonga as a major regional centre over the years, and it has changed significantly from the large country towns that it used to be to a major regional centre. And my concern so much is to have a health service that is commensurate with the size of our region and the importance of our region to the nation. So I have been very much involved with the Board Medical Association in our attempts to influence the redevelopment of the infrastructure, and I understand the frustrations that we've all felt during that time, and I'm just hoping that today can lead to some positive outcomes.
I'll go back to you, Jane, first, because we're starting the clinician journey with education. Could you tell me about any collaborations that you are currently participating in that actually increase your remit or strengthen the remit to educate the future workforce? And we'll go back to Philip after about that too, because you're in the medical education area. I'd just like to see some of the changes and where there are still opportunities. I mean, in this region alone, we have the manufacturing sector, we have the defence sector, we also have service sector, and I know that the people that work in those sectors are very well supported. We don't tend to do the same for our students, trainees and workforce in health. I'm just wondering, are you collaborating in any way with others?
We are, of course. The La Trobe Rural Health School is Australia's largest school of rural health, and I think that gives us quite an interprofessional approach to the way that we work with our health partners. I'm working with the 5 CEOs, including the Albury Wodonga CEO at the moment, of our major regional areas, so that's Mildura, Bendigo, Echuca, GB and Albury Wodonga, to develop an employment pathway for undergraduate and postgraduate nurses. So we're just about to introduce next year a new graduate entry Master of Nursing practice degree, which will allow people to change careers. So that will be somebody who might have an undergraduate degree in education or in accounting or business, marketing, something along those lines, who wants to become a nurse, we're able to come into a postgraduate program and do that course with us. But also the undergrads in the Bachelor of Nursing, also occupational therapy, the physiotherapy degree and social work. So we're looking at those courses as a starting point and working with the CEOs to co-design an employment pathway whereby we actually can create opportunity for those undergraduate students to work in health services, to really sort of pair up. So we're tentatively calling it a Nexus program, which is based on our very successful program in the School of Education at La Trobe, which just won a Shaping Australia award on Tuesday night at the Universities of Australia conference, which was great. So we're using that model and working with health services to think about what that might look like for them. All of the different rural health services have got different levels of resourcing and different capacity and capability to contribute. So we're brainstorming with CEOs and their teams around what that might look like. Doing a desktop analysis at the moment, investigating other countries, particularly the UK, that have had employment pathways for undergraduates in place for a while, to see what other things we might learn from that, and then coming back and testing some models. So we've got quite a bit going on there, and we're hoping that, we're aiming for the idea that 20% of our cohort in those degrees will have the opportunity to get a nexus place with an organisation that actually creates a relationship between that organisation and the student during their degree program, really getting them to understand the culture of the organisation and creating opportunities for paid employment as they're going along. So we've got that happening. That's quite a lot happening there, and it's busy. The other big thing we've got is in partnership with the University of New South Wales and Charles Sturt University. My colleague Megan's here today. So the 3 universities in the area have come together along with Albury Wodonga Health and the military and other key stakeholders, and we're pulling together a proposal for an education and research centre to be funded and developed on the campus of Albury Wodonga Health, and so that will then provide an opportunity for existing workforce, so clinicians, to be able to really ensure that they have the opportunity for professional development, so maintaining of competence and really making sure their skills are up to speed, but also an opportunity for research to occur. And we know that for clinicians, particularly mid-career clinicians, it might be 4 or 5 years out, the opportunity to participate in research activities and job craft in that way is a great incentive for them to stay in roles and provides a lot of rewards. So we've got sort of 2 main areas going on at the moment, Susie.
Thank you. Before I move on to Philip, what percentage of your students are from rural Australia?
Oh, we're very proud of that. Thank you. I'll take that as a Dorothy Dixer. We are in nursing. 92% of our students are of rural origin, and overall in the La Trobe Rural Health School, over 80% of our students are. Even we've got, we are the custodians, or we, teach the dentistry and oral health programs, also physiotherapy and the double degree in nursing midwifery. So those are really high demand courses for us. And yes, I've instituted regional pathways for those. So dentistry this year, we're very excited. Over 80% of the commencing students are students of rural origin. And when I first started in 2020, it was under 10%. So yeah, we were a definite backdoor for Melbourne to come do
wonderful.
dent. So yeah, we've changed all that.
Yeah, because we know that exponentially, if you've gone to primary school and secondary school, and then you've also been at university in a rural setting, it's up to 7 to 8% more likely that you are going to stay. So it's fantastic. Philip?
Yes, well, I'd add to that. There's been some really, we talked about research.
Richard Murray, you're talking about.
Richard Murray, I was trying to think of his name before when I was talking to Susie, but a beautiful study was done by Richard Murray at James Cook University, looking at rural origin, it's rural origin students, rural clinical school students, internship and junior doctor training. The more of those things that you do in a regional area, the more likely, significantly more likely you will be to end up as a medical practitioner within those rural areas. It's been known anecdotally for many years, of course. We've seen it all the time, but there is now proper evidence to demonstrate this, and really needs to be encourage more funding and more expansion of the training opportunities within rural areas. I think Jane mentioned the Collaborative Health Education and Research Centre. I think that's a very exciting development that a lot of work has already gone into application for some funding to get this moving, and thank you, Helen, for helping with this. Such a centre co-located within the acute health service will make such a difference to the attraction or the attractiveness of the place of the health service to medical practitioners. We know that there are strong demands for many specialty trainees now to have produced a significant number of research articles, and we need to be able to be the site where they will want to do that. And if we can collaborate to share resources in terms of the research, the groundwork of research, statisticians, epidemiologists, they don't all have to be siloed within the individual universities. If we can join together to make those happen in one site, it will really enhance the status of Albury Wodonga Health as a major health education and research centre.
A hub, yes. I mean, you raise a couple of really important points. One is about local research. from a career perspective, being able to have another side of your career, but also having local research with the community. And we've fought really hard that NHMRC and MRFF funding is actually spent in rural and given to rural rather than urban centres doing research onto rural communities. You know, that funding needs to increase. I mean, 30% of the population live here. You deserve 30% of the funding. I was just going to move on to Peter. Peter, you've known the education sector, doctors all the way through their journey. Tell me about some of the cultural things that you've noticed over the last few years. How's that changed? What do we need next?
I think it was in one of the presentations earlier, I think Matt talked about it, about, you know, the doctor that comes to a town, stays 20, 30 years, and then that's it. That's definitely gone. If you're lucky, we talk about often, you know, 5 to 7 years, but we're also talking, we've got, particularly in regional, rural and remote Australia, we've got an ageing medical workforce population, and what the reality is it's not a one-for-one swap. We're often talking a 1 to 2 or 1 to 3 replacement. And it's things that doctors might work full-time, but they won't work clinically full-time. So they'll do research, they'll want to be involved in medical education, they'll want to be involved in advocacy. There's a whole range of things that doctors, and not just doctors, but allied health professionals and that will get involved in. They're looking for other things, not just the clinical work. And we've got to find opportunities to facilitate that. I think, you know, the work-life balance, they're very conscious now, and again, this is not a doctor-only thing. This is the generational thing where there is work-life balance. It's not all about, you know, working 70 hours a week. You know, for surgeons, that's frowned upon now. You generally get reported and told, no, you know, stop working. So there's a whole culture shift. I think also our workforce is much more transient. And again, you know, doctors can get a job anywhere. So can nurses, so can midwives, so can physiotherapists. And again, they won't stay necessarily in a job for, you know, 20, 30 years. So we talk about retention of around 5 to 7 years is reasonable. When you're in a really small remote community where potentially the medicine is really hard, you're probably going to get 3 years out of someone before they need a change. They're not going to leave their health profession, but they are going to leave the job. And I guess what we're looking at is how do we retain these people and give them those other opportunities in our rural and regional communities, and how do we facilitate movement. And one of the things that our organisation's particularly keen on is a single employer model, where at the moment there's some pilots, and I hear a lot of talk about Wagga. I will say that the CEO and Murrumbidgee is looking for every opportunity she can to put her hand up and say, we'll go first, we'll get involved in this. And she's developing quite a reputation of doing that. And so Murrumbidgee was the first site to be approved for their single employer model, where junior doctors were employed basically from intern by the health service, and they're going to be paid by the health service right through to when they finish their training. Now that's including when they're in general practice and including when they're doing their work in the hospital. Most doctors in a training program have to reapply for jobs every year as a resident. So you apply for a job as an intern, then you apply for a job the following year, then you apply for a job the next year. For the people involved in the pilot, they've been given 5-year contracts. So they know they're well situated for 5 years. So I think we need to look for the opportunities. Like, why do we make these people reapply for jobs? Like, that's the system driving, you know, the service type thing. It makes no sense. It's not essential. It's just, that's the way we've always done it. And certainly from my perspective, the moment that's the answer to a question, that's the way we've always done it, means it's time for change. That should not be the barrier. So there's lots of opportunities. I think it is about being innovative, taking, you know, advantage of those opportunities. But our workforce is different. They've got different expectations, and we need to look for opportunities to how we take advantage of those expectations. And Albury Wodonga's got a huge amount to offer. Like, you've got good schools here, you've got great lifestyle, you can have a great upbringing. You don't have the issues that, places that are much more rural and remote have. There's so much on offer here. But it is now about what the culture in the health service has to offer, and that's primary care and acute care, and how it all works together. And something like, I heard the comment before, something like making a clinician move from one campus to another is annoying. And that is one way where that is a frustration for the clinician. So they'll look for a job where they don't have to do that. So it's about, what are the barriers in place? How do we remove them?
Thank you. Can you think of an example of where you've seen that work well?
As in the culture?
Yeah.
There's lots of examples. And so Riverlands in South Australia is an amazing example. They've got their single employer model up and running. I will say, in relation to doctors recruit doctors, and doctors are the biggest gossips. So if they go to a place where they find the culture's bad or the work environment's bad, they will tell everyone. And I've seen this not in Victoria so much, but certainly in Queensland, and I'll name it, Rockhampton Hospital has had in the past lots of challenges about recruiting interns. They built it up, and then there was some management changes, and the interns felt that they were, not treated as well again. And they struggle to then recruit interns. Junior doctors talk among themselves, and if they feel that there's a place where education and training is valued, they will share that. I used to work and manage Kingaroy Hospital, and we had really great medical leadership. We had 2 permanent doctors when I first joined. We had great medical leadership. They built it up. They valued education and training. And when I left, we had 18 permanent doctors working in that service. And it was a small rural hospital. It turned a bad news story into a good news story. There's the culture and the values of an organisation is so important. And it's not just about doctors, it's about how they work together and are supported in the multidisciplinary team. Doctors, and particularly doctors who do obstetrics, if there's not a great team of midwives working alongside them, they will quickly leave as well. So it is about the team and how everyone works together. But the culture is so, so important.
Thank you. Jane, and Philip, because you both work in the health education sector, have you seen any innovation, and it doesn't have to be in your region, but have you seen any innovation where you see universities and clinical schools working with industry and the hospitals that are actually quite different and quite out of the box in terms of sharing resources, a different way of learning? Many years ago, I'm not sure if people know Lucy Walters and Paul Worley were trying to set up the Flinders parallel rural curriculum. It was quite innovative at the time. There was nothing like it. And I ended up getting the winery industry, the wood chipping industry, agriculture all together, including community and schooling. And we developed a plan where we could actually look after students. So we built houses. The local government was involved. I know that this, you've got a municipal health plan. We ended up including all of those industries in the training program. Now that's commonplace now, but at the time there was nothing like it. And I guess the question is what's the new iteration? What new things are coming out that actually show integration and sharing of resources rather than universities working together?
So we've established at the Latrobe Rural Health School the Rural Health Innovation Lab. So that's been going for a bit over a year at the moment, and that lab group is charged with coming up with co-designed innovative models of clinical placement. That's what its main mission is. And so the team there, led by Dr. Brad Hodge, have been working really closely with industry, coming up with some of these new and innovative models. So we're just about to launch a clinical placement with one of the bush nursing services, where we're sending students out with the bush nurses to provide a new model of service to that community around preventative health and screening that wasn't in their original work as a community health, bush nursing service. So that's really good. So we're starting to see our students being seen as a really valuable resource. I suppose it can value add to existing services. So that'll be a really interesting trial, and it'll be good to see how that goes. But we're also in conversations with the Education Department at the moment as well, and also our colleagues in the School of Education, to think about pulling together an interprofessional team of education students, so undergraduate teaching students, social work students, speech pathology, in order to provide, again, another pop-up service going in to schools, so that they will actually go with a clinical supervisor, and we'll have some long-arm supervision for some of the disciplines who that person is not. So there'll be mechanisms by which the students' sort of performance is monitored through the university. So coming up with ways, what I like to call service learning models of clinical placement, where we say, okay, we've got smaller rural and regional towns, where can we value add with our students with existing services? So those are a couple of examples, Susie, of things that we're doing in the Latrobe Rural Health School at the moment to try and create clinical placement that makes a real contribution. Our vision for the school is to make rural health and wellbeing matter.
Actually, there is another part that you haven't mentioned, and it's the School of Psychology. That actually, there are psychologists all the way around their region that are generally strapped for time. They have so many clients or patients. And one of the things that you're doing is you're actually funding their paperwork to allow that person just to teach.
So finding new and innovative ways to relieve workload stress.
Which is actually really important, because the amount of red tape that any clinician, it doesn't matter which profession it is, has to put up with, it is becoming bigger and more time consuming, and it actually stops you from delivering care. So.
Yeah, well, I can probably add another example in a similar line to that. This is from Tasmania, a beautiful model of a GP supervisor who basically does minimal consulting of their own patients, but is supervising a number of medical students and junior doctors who are consulting with the patients, and she's basically works around the clinic, just advising, assisting with the training of these other junior doctors, but doesn't have the workload herself. So it's freed her up to do the intensive teaching, to sit in with the junior doctor while they're seeing the patient, and really try to be able to spread her expertise around, which really, in the old system where she just stuck in her room and putting out fires all day, did not work. So those sort of innovative models of training work nicely. How that applies to the broader picture here is a different thing.
Well, it's interesting, isn't it? Because we complain about not having the workforce across all of the sectors, and we're willing to fly in either locums or short-term people. It doesn't matter which the profession is, which actually costs us 3, 4, 5 times more. And if we invested in the very beginning, we would actually be able to develop the next workforce. And so that is a problem. It's probably one of the biggest messages that the grassroots tell us about. Peter?
Yeah, I guess just looking at Albury Wodonga, I think, there's a huge amount of opportunity, and the numbers for the Australian College of Rural and Remote Medicine for their rural generalist training pathway intake for 2024 was huge. Now, there's 2 GP colleges, and Akram's the smaller one, and they run a... Purely rural. Yeah. And they run the rural generalist training stream, which has 100 positions on it. They had 190 suitable candidates for that program for the 2024 intake. And Albury Wodonga is would be in a really good position to train rural generalists for, you know, with the skills which include emergency general practice and an area of advanced skill for places like Yarrawonga and all the regions, all those small towns here, with Albury Wodonga being a core hub. And it's that thing of when you train the doctors that work in the regions, you have more trust and I guess in them that, you know them, you know their skills, you know what they can do, and it helps with that integrated model. I think that there is, you know, a huge amount of opportunity for multidisciplinary training here, and for career development and support. And, you know, I think there are these little nuggets of hope, I guess, out there. And certainly from a Rural Doctors Association perspective, we look at rural generalist training as an absolute key. You know, we understand that there'll be consultant specialists in Albury Wodonga, which is absolutely needed, but for them to be training rural generalists and for them to work as an integrated model for the region is absolutely key for the sustainable health services, I think, into the future.
Can I just add something to that, Susie? Sorry, Matt talked about the general practice and the terrible numbers of applications of
13%.
graduates who want to pursue a career in general practice. My sense, since rural generalism has been really promoted as a career pathway and the extra training that goes into that, there's a sense, there's a turnaround, there's a sort of a sense of excitement amongst the young graduates and medical students that I meet and talk to, that this is a career that they could really appeals to them. General practice in general has been starved of funds for a long time, and it's really lost its impetus and has lost its status in the medical world. But I think rural generalism, and these are the people that we're trying to train to work in rural and remote areas, as well as regional centres with special skills. There's a fantastic opportunity to really build on the momentum that exists.
And it's a form of medicine that is so broad and so exciting. It's the same as those people that work as rural nurses. I mean, the breadth of interest and the breadth of cases that they see is just really quite amazing. I was just going to mention one thing. I mean, I think the decline of general practice as a career option has partly been because of communities and clinicians being set up to fail by stating that Medicare is supposed to be a full payment for a service. It's not. If you look at the legislation, it states it is a subsidy to the patient. And I think we need to change that rhetoric, for one. I mean, we've spoken with psychologists that have closed their practice in rural. We've got communities that cannot afford to fund their multidisciplinary clinics, and they're raising funds, $800,000 per annum, out of the community. Like, why? You wouldn't get that anywhere else. And so I think it's really a combination of different training models, different ways of promoting the benefits of working in a rural and remote community. The mentorship, we spoke about culture before. Now, Peter, you were going to mention something leading on from Philip, I think?
Yeah, I think just with all of the funding models, and I mean, there's, you know, general practice gets a bad rap. It's, you know, our members think it's a great job. I think rural generalism fits into this thing of doctors wanting an element of diversity in their career, and rural generalism gives them that. So I think that is part of it. I think, you know, for general practice, one of the challenges is that particularly for rural and remote, the MBS funding model is no longer fit for purpose, and that's certainly our position. We need to look at a different funding model. We need to recognise that doctors, primary care nurses, other healthcare professionals, allied health midwives will move across both the primary and secondary sector, and we need models that facilitate that. So the funding model needs a lot of attention, and I think, you know, that will help reposition general practice. And again, I think it's about what are the expectations young doctors coming through. Certainly I do a lot of work in Victoria around the GP VMO contracts for rural GPs. Try and tell an early career doctor whose parent isn't a GP what they can earn in general practice or as a rural generalist. You can't. And the figure out there at the moment is based on the national terms and conditions. That is not what registrars earn. They earn more than that. So I think we have to have honest conversations. We have to have, you know, conversations about what is the career, what are the benefits. You know, we compare apples and pears generally when we're talking about what doctors earn. We need general practice to be, you know, competitive with all the other medical specialties. We need it to offer the same benefits as all the other medical specialties, particularly in the training years. You know, because all of the other medical specialties train in the state health system. So they get the benefits of accrued leave, paid parental leave, all that. GPs don't get that at the moment, so that needs to change. But I think, you know, it's really important. We just look at the structures, the barriers, and address them. And certainly the funding model is a key inhibitor for rural general practice at the moment.
And that goes across all the other areas too, because we often find anyone that works in a primary care setting, whether they're nurses, allied health professionals, they are being paid less than the state system in the same region. And how can they survive? I mean, you will continuously lose people, and that has to change in a rural setting because you can't go down the road and go to another service. So, Philip?
Oh, no, I was just trying to bring it back to Albury Wodonga Health and how we, as a medical community, can facilitate this process. Clearly, we're not going to be able to influence the Medicare benefit schedule.
Don't worry, we're trying.
but our little patch here. But in terms of Wodonga Health as a regional health service and as a training ground for medical practitioners, nursing, allied health, we have a fantastic opportunity here to be a factory to produce not only practitioners to work within Albury Wodonga and our region, but in the broader region and in all over Australia. So it's, but to do so, we need, despite Jane's point about the infrastructure being not the key driver of education and training, you still need a level of infrastructure which is going to enable this to happen, where multidisciplinary training can happen, where medical students and nursing students can learn together to form those bonds that will potentially be lifelong, to really sort of bring all the health professions in together to train in one location.
And you're just asking for equity. You're not asking for anything else. Okay. It's not unreasonable. I just want to make a couple of observations. Then I will be asking you the last question before we open up to the floor, and which will have 20 minutes just to ask some questions. The municipal health plan, which is just about to be reviewed, I believe, it's going to be renewed, is a fantastic opportunity. I mean, you've taken some great leadership, and I've found that we work with quite a few local government entities around Australia, and often they get involved in this when it's basically at the brink. And it's fantastic. And in 1876, when the Wodonga Shire Council was created, it was purely because all the stakeholders, and it was a ratepayers petition that allowed that to happen. And I think here again, on behalf of the ratepayers, I mean, they would want one system, they would want it to work well, they don't care who delivers. So that's a really important strategy for the council. Just to go back, there's one question I'd like to ask all of you. If you gave the City of Wodonga some advice, and I'm not only talking about the council, but just in general, what would you suggest the governance, the methodology and process should be for this community. And you can be bold because there are a lot of elephants in the room. Oh no, we'll start with Jane. Put her on the spot and then we'll go to you and then Philip.
I think it's important not to throw the baby out with the bathwater. I thought David's presentation was really interesting about the work that's already been done. So there's been a lot already done in terms of consultation and co-design. It's disappointing that from his perspective, and I'm not quite sure, I mean, I can only take what I listened to this morning, that notion of sort of co-design and collaboration appears to have sort of fallen away a little bit. And I think I would, suggest that probably the way to sort of go forward would be to pick up maybe where the 21 plan left off in terms of the co-design element that comes with it and that sense of actually coming together to find a common ground. So, yeah, I think probably going back to maybe resetting the communication and consultation around this might be helpful.
Thank you. And we often talk about health literacy and health system literacy. And if you're not collaborating and you're not bringing the community along, well, how they're supposed to have that. So that's important.
Yeah, I agree with Jane's comments about, there's been a huge amount of work done. I guess there is a plan, and in a lot of places there's often not a plan and they're sort of saying we need a plan. So you've got your plan. I think it is about educating, and I guess picking up on the point that, the Treasurer didn't know what the situation is. And I guess, there'll be times where groups like Border Health won't get in to have the meeting, but there are other avenues. And certainly we met with Helen Haynes 2 weeks ago now, had a long discussion about Albury Wodonga Health. But it is about the perseverance. I think that is absolutely key, and finding not just a single voice or a single organisation to push the agenda, but many. Nothing annoys politicians more, than people constantly bringing this up. And it's not just about your local members, it's also about the Treasurer, about the health ministers, about the assistant health ministers, about the shadow ministry, a whole range, and even what you might think as some of the less influential backbenchers. I didn't know, but, there's all these party room health groups and things like that. I've been to the Nats Health Policy Party Room. That was interesting. But, there's lots and lots of different voices or different influences within government. And I think, stick to your plan, stick to the goal and the objective. It's really, really important because you've got some direction. And I think that's often part of the challenge with advocacy. If there's no direction, it will fail. You've got direction. And there is a goal, I guess. And there's so much potential in Albury Wodonga. And I agree with Phil's comments, but without that sort of, infrastructure to support it, it's, potentially going to fail. And that, you can be as innovative in that, but you're constantly doing Band-Aids, and Band-Aids will only hold it together for so long. And as the presentations were on this morning, I kept thinking what I often say to my husband, he who buys cheap buys twice. And I think that's what Albury Wodonga Health is potentially, at risk of. They'll do it, it will be very quickly identified that they need more and need further investment, and that will be a shame.
Thank you.
Pretty hard to add much more to that. However, I would say that it's so important to have a united approach to what it is that we're trying to achieve. And it certainly has felt from a Board of Medical Association point of view for some time that we have been yelling out there in the air, and nobody's been listening. But I'm have a growing sense of optimism that more and more people are interested in this as a significant issue. And if we as a community, and the important thing is to get this message out to our whole community that we do have a fantastic health service here, we want to make it better, and we want to make the ability of the people who provide that service to our community to work in an environment which enables them to do it properly. So united voice, saying the same thing. We don't need to reinvent the wheel. We know all the work that was done to develop the clinical services plan in the first place. We need to keep pursuing that.
And I was just going to say 2 more things. One is industry. They have a social contract and they all report against the social contract. They should be doing more work with you. And the next one is that you need the federal and state compact. If you don't have that working together, you're just not going to get the change that you need. So that's it from me. Thank you. I just want to say one thing before we go open to open questions. The 3 of you are passionate rural people, and it's so important to have these sort of people, because there are days that you feel frustrated and you're hitting the head against the wall. But thank you very much for being here and always being there.
Fabulous. If you'd just like to thank the panel, because it was a sensational section. And I've stepped up here to sort of guide the questioning, so Susie, you can participate as a responder as well. And we do have a roving mic. If you would, when you are going to put your hand up and ask a question or make a statement, say where you're from so that we can capture that as well. You can direct to the whole panel or pick someone specifically, and we'll just manage this before we go to have some morning tea, and we'll be needing our coffee. It's been a very intense morning with some fantastic presentations of, the real focus being that I think this panel has given us, that regional and rural areas need to get together. They've got the skills, they've got the experience, they've got the passion to actually lead for regional and rural areas. So, hands up, anyone's got a statement to make. We've got one over the back. Over there, the lady with the, she.
Hi, my name is Vicky Lancaster. I live in Wodonga and need a knee replacement. But one of the things that I've heard over and over and over again from many different things is the lack of housing here. If we are looking at bringing more people in, are we also looking at building them housing to live in, so that they're not trying to find somewhere to live when they get here?
I think that's a general question, and I'm sure there'll be some responses, and I think it's that broader question in terms of needing to look at the housing and other infrastructure as well as the health. Is there any specific short responses?
We're definitely working with the Regional Australia Institute on infrastructure and housing, because you can't bring people to a community, and that includes social housing. So, yeah.
Absolutely. I think it's a very key lead in this area, that you've got to have places for people to live, particularly for if you're going to be attracting fabulous, new people to the area. Helen has got her hand up.
Thank you, Vicky. Helen Haynes, member for Indi. I just wanted to comment on housing, because it's critical when we talk about the social determinants of health, which is where we began, and about the intersections between what people need to live a healthy life and what we need to build the workforce to operate in world-class health facilities. We've got to have housing. So to that point, and to Susie's point, working with the Regional Australia Institute, I was at a forum, I spoke at a forum recently. I've been presenting bills to the House of Representatives. We need 30% of the federal funding that's going towards social and affordable housing to come into regional Australia, commensurate with our population. And of that, we need key worker housing funding from that fund as well. And in addition to that, we need We need budget and funding into rural and regional Australia for the critical enabling infrastructure, the sewerage, the pipes, the poles, the power, the internet, the things that enable housing to be built. So it's all part of the same picture for a healthy, thriving, prosperous rural Australia.
You raise a really important point because industry often funds housing. So for example, if you've got in the minerals industry, they often provide housing, in the police force, in defence, and for some reason we're not able to offer that to health workers.
We've got another. David.
Thank you. Sorry to be overbearing and having another say. Look, again, let's have a blank canvas. We've talked about what needs to be done, and let's give some local context of how it is currently being done. Just 2 comments before I get to a question about colleges and funding. Number one, we are, because of what we've done to general practice over 10 years, going to need to look at what we do for acute and subacute facilities. And don't forget that Albury Wodonga Health is also community services. And that will put more pressure on that until we get that right. But I think coming back to the training component, and sorry, Peter, your point about your best recruitment strategy is your retention strategy. You churn and burn. Don't worry about university and novel training models. You won't get anybody. And that will come back to the built environment, it will come back to the IT, and it will come back to the culture. From the training point of view, yes, rural generalism is very, very important. But go and have a chat to the local people, the Director of Emergency Medicine Training at Albury Wodonga Health or the ICU Supervisor of Training. And they'll tell you about how last week they got asked for the 9th different college accreditation paperwork to be done and then be interviewed. Australian College of Emergency Medicine, Royal Australian College of GPs, Australian College of Rural and Remote Medicine, Rural Generalist Training, back to ASIM for ultrasound training. It goes on and on and on. How do you streamline that for the practitioners that are then soaked up doing that? And then the second question, so that's from a college perspective of actually start to work together. Second thing is about the funding for training. Again, the paperwork, the models, the waste. VRGP, IRTP, STP, whichever acronym you want to go. Different state models, federal models. IRTP funding, federally funded. Put a trainee in a regional town and get them to do the entirety of their specialist training. Correct me, Phil, $36 million over 5 years. Albury Wodonga Health, through that mechanism, has had 1 trainee. It's inefficient. It's waste. How do we get the feds and the states, get the blank canvas? We can talk about what we need. Now let's talk about how we do it. Streamlined, efficient, making it easy for people to do. And sorry, the last thing, because there's another skinhead in the crowd that will kill me if we just talk about training for doctors, nurses and allied health. Very important.
Thank you. Yes.
So you've hit something that the rural doctors is absolutely passionate about. So STP and ITRP is up for review again. We agree with you. And I've sat in a large number of college meetings where they present their rural pathways, well, what I call the non-tertiary hospital training pathways, as their regional and rural pathways. It's a joke. And we, I guess, have started to call out the individual specialty colleges, the way they do this. And again, you know, for us, the physicians are on notice. The physicians, you know, the moment anyone's back's turned, will try and, pull back on their commitment to rural training. They're doing it with paediatrics at the moment. We've, written to them and, if they're listening, we'll be continuing to ask questions. We're asking the department questions about, what are the outcomes? And often with the Commonwealth, we're measuring process. We measure that someone's, in the job. We're not actually measuring where they're ending up once they've finished their training. We're not measuring the outcomes. We're not putting targets on outcomes. We're just measuring process, and that needs to change. And when we talk rural training or regional training, we're not talking out of metropolitan modified Monash 1. We're talking the regions. Our definition of rural is modified Monash 3 to 7, the regions is 2, and Albury Wodonga is a 2. So the regional training for the non-GP specialty training, you know, Albury Wodonga should be getting more than one position. That is absolutely critical. But it is also about then how we work it with the states as well. But this is on our radar. It has to be. We have to be asking more questions. We have to not just be challenging the government about investment in that. We have to be challenging the specialty colleges about what their social obligations are. What is their contribution? How are they picking candidates? And they need to be held to account.
And can I add to that? There is,
Yes.
this is a very real problem in medical training in Australia, and our beloved specialist colleges can be an impediment, or they can be an advocate. And certainly there are colleges in Australia, specialist colleges in Australia, who are very much looking after rural training, and particularly the College of Psychiatry has developed some really innovative models of training in rural psychiatry, and most end-to-end training can be done rurally and regionally if the candidate desires. But I think this is where again the regional voice needs to be heard loud and clear, and not just through doctors' organisations like RDAA and you know, the various GP colleges. It's the communities and the community leaders who need to be at the table, encouraging the controllers of the purse strings, and this is federal government money, to influence the specialist colleges to change their policies in terms of accrediting training posts within rural and regional areas. They do not seem to be able to recognise that things are done differently in rural areas. That the training, we know the training is equal, if not better, than the training that a candidate will get in a metropolitan centre, but because it's done in a different way and it doesn't fit into the boxes that are set, the accreditation doesn't occur, so we miss out on trainees.
Are there any further comments? Because we have another question here in the middle of the room, or statement.
Thank you very much, Georgie Crozier, Shadow Minister for Health. Thank you for the very informative discussion this morning. And you've spoken about a number of barriers, and one raised by Vicky about housing and other issues that you've raised. I'm interested in your views in relation to government policy, and I'm particularly interested in barriers to general practice. I've been very vocal on this. A payroll tax that will be applied to general practice that will effectively, according to the AMA and RACGP and other groups, will say that 30% of GP clinics will be shut down, bulk billing will end, and that will largely affect rural and regional patients. And I want to know what, if you have a view about, you know, government policy in these areas as a particular barrier to providing good healthcare to rural and regional Victorians.
Who would like to kick off on that one? Jane.
Yes, thanks for that question, Georgie. I think that there are well-recognised issues around the funding mechanisms, in particular for nurse practitioners, that really constrain, I suppose, the level of service that's able to be provided. Matt and I were having a conversation earlier today about that, and of the 100 nurse practitioners that are in the Murray-PHN region, only 20 have been able to secure employment because the jobs are not there. And that is largely down to funding and the policy that surrounds that. So until we actually see a change around that, and there has been some changes to legislation which have enabled greater scope of practice to be enacted by nurse practitioners, which is great, but you know, we need to see more. And so there are some really big constraints we need to start thinking about the health workforce as not just being doctors. And until we, I also, a bit of a disclaimer, I sit on the Medicare, Strengthening Medicare Task Force around scope of practice, and actually really enabling people to work to their full scope of practice. A lot of that is around legislation and policy, but there's also some particularly unique things in Victoria. For instance, the only people that can provide public dental health services in Victoria are community health organisations. So for universities like ours, we are constrained and unable to establish a university dental clinic and access public service funding to be able to do that because of legislation. And the department are not interested in talking to us about that. So I think there are definitely some areas that, we could see some changes in that would free up, I think, our ability to be more flexible in terms of service provision and for people to be able to work to their full scope of practice.
Anyone else on the panel? Peter, Philip?
I'll just say the funding model. It's, similar to the whole multidisciplinary care, certainly from a rural doctor perspective, it's about the team. And the more remote you go, the team becomes more and more diverse, and often it won't be a GP that's coordinating the care, it'll be the bush nurse, and nurse practitioners are a huge value in the service, but the funding model doesn't support it. And often I sit in meetings where I hear midwives or nurse practitioners say, oh, we need an MBS item. What I would say is that fee-for-service in rural and remote is broken. GPs are telling us that. Don't put the same model in place then for nurse practitioners and think that it's going to be a different outcome. If it's not working at the moment, let's not continue to, use it. Let's actually fix the there and a change in that funding model will facilitate much more multidisciplinary care.
I was just going to quickly say there are a lot of reviews and reforms going on at the moment. The problem is that it's not population health based. The decisions are being made at a local level. And I think it's really important that the decisions start being made about local level, and also because there is no ability to cross-subsidise in rural remote in particular, but also regional, there needs to be different funding models available.
It's all right, I'm just going back to the question again.
Thank you.
To clarify.
Absolutely. What I mean is, when these clinics close down, it will affect multidisciplinary teams that you've highlighted. So it's not just the nurse practitioners that won't have an ability to practice and provide that care. I'm a former nurse, midwife, diabetes educator, so I understand exactly what you're saying. So there has to be a review of that policy, I believe, to prevent that from occurring. So I fully take on board what you're saying as well.
Can I just add something to
yes,
to that, Georgie?
Please go.
You mentioned the payroll tax issue, which is obviously a national issue that's happening state by state. And I don't know if everyone understands the situation, but many GPs now work as independent contractors within a private general practice. They are not employees of the practice. They determine their hours, their days that they work. They pay their own superannuation, sick leave. They are independent contractors, but and therefore payroll tax was not payable by the practice because they're not employees. That's now changed in a number of states. There have been moratoriums placed on the application of this law, but it has really significantly rattled the industry of general practice. The welcome changes to Medicare rebates, increases in Medicare rebates that were announced by the federal government late last year, I think it was. Really, it's giving with one hand and taking back with the other, and the financial viability of general practice, which is largely a bunch of small businesses scattered around the country, that financial viability is being threatened. And as Georgie very much points out, the real impact is on our patients, because many of these businesses are going to have to increase their fees to cover these costs. Bulk billed services are higher in rural and regional and particularly remote areas because the population just cannot afford to pay large gap fees to go to see the GP. So the impact is greater in rural areas.
Thank you. We have one last question of the panel.
Thank you. I'm Bruce Bolam. I'm Chief of Strategy and Performance at Murray Primary Health Network with Matt. And we've heard a lot today about the benefits of place-based approaches to integrated health, from prevention through to primary care, through to secondary care in regional and rural. And Petty, you specifically referred to looking at innovative models for funding of primary and secondary care from a place-based perspective. And I think there's an interesting different examples and experiences, particularly through the pandemic, where, of course, Albury Wodonga was very heavily affected because of those, because really of the policy and legislative boundaries that impacted the health experience here very profoundly. I could contrast that with Beechworth, just down the road in Victoria, where there was basically daily huddles happening between the public health unit, the local general practice, the local hospital, and every day activities occurring, vaccinations happening, integrated care, managing both the prevention and also early intervention and care. And that was driven very much in a crisis environment. So I'd be interested to hear from the panel about what you think some of the lessons coming out of the pandemic are, particularly in relation to our place-based approaches to integrated health, from prevention right the way through to secondary care.
I think we could have a whole panel session on that, but a fabulous question. And I would ask for a comment from each of the panellists, because if we don't look back and reflect and review on the experiences that we've had and use those to look at different ways going forward, we're challenged. So,
well, just a quick one from general practice. The COVID was the game changer for telehealth. Telehealth was happening in a relatively minor way, particularly in remote areas in Australia before COVID. But my experience during those years was of a dramatic change in the ability and the thinking of how one engages with patients in general practice. No longer did every consultation have to be face-to-face. We could see people and effectively do what needed to be done remotely. That clearly was not sustainable on a long-term basis, but it's really driven the IT changes that were the enablers of that telehealth process, and it's now really grown in areas where, particularly remote Australia, where access to specialist medical practitioners is absent, where nursing staff who are staffing these tiny little bush nursing hospitals can now get access and utilise their skills that they've trained into to their fullest extent. So it's telehealth is my thing from COVID.
Susie? Yes.
I was on one of the first telehealth advisories, and I think it was 18 or 19 years ago. And we were developing the MBS item numbers for telehealth. And at that stage, we'd fought for psychiatrists to sit in the city, and somebody in the country would be sitting in the broom closet speaking to their psychiatrist. And it took us, I think it might even be 20 years, I'm showing my age. Anyway, and then all the way up to here. It was never meant to be instead of, it is in addition to, but it has been one of the best outcomes. You shouldn't have to fight for 20 years to get something like this, and I think it's a lesson to this region. Don't wait. Just try to work together. That's the first thing. The second thing is that communities, we've spoken to a lot of communities, they work together with industry, across health, all the forces of any sort, like police force, emergency services. It was fantastic. So it brought out the best about collaboration. And the third thing is, we have learned that we cannot keep relying on primary care and those that are there in times of emergency, and continue to ask them for more and more and more and more, because they're burning out. And we have a social contract to make sure that they are looked after and they are actually supported for what they provide, not consider them, they're doing well, they are earning good money.
they're burning out. You don't need another COVID to decide that you're actually going to do something.
Thank you. Jane, Peter, any final wrapping up, looking back?
Oh, I think that, that question about what constitutes a basket of service for a local place is a really important one. And I think that that's something that can come out through things like the municipal health plan that's going to occur. And when I was at JCU, I'm a JCU alumni as well, we did quite a lot of research up there in and around that in Yarrabah and up in the Atherton Tableland. So, I think there's been some really good research in years gone by that has used that co-design, working with community, collaboratively, actually designing a basket of services that fits with that place. And I think that, going back to basics around that type of communication is really important.
Peter?
From crisis comes opportunity, I'll say that. But I don't think we started well, but I think one of the things we did over the pandemic and we got better at was how we bring GPs into disaster planning and disaster response. We've never done that well, unless, and I used to live in Charleville where it floods, used to flood all the time, they've got a levee now, but the disaster planning was always schmick and they did it for every scenario. And I think through COVID, the importance of disaster planning, the importance of having GPs and primary care as part of that response became really obvious. And I hope that state governments continue to focus on that it's not forgotten, that it is now integrated into the state disaster planning, because primary care is a huge resource and a really valuable one in every disaster.
Thank you, and that's a fabulous point to end on, because New South Wales State Government released the State Mitigation Plan last week, and very much that is around looking at the planning that we need to do in terms of preparation, but also moving into response. And one of the things I think across Australia we've done very well has been responding to disasters, and we learn and we learn. We don't really plan or exercise or think about the moving into recovery, whether that's a flood or a fire or a pandemic, and I think that's really been picked up now. So I think that's a fabulous point to end on, and it does segue into the importance of municipal plans, working with community, being place-based and collaborative, and looking at all of those things, looking back to the future to get a better future, I think. The panel has been fantastic. What skills and experience we have. So again, if you would thank the panel with me. And we now are moving into morning tea, and there is coffee and a chance to have a bit of a break. And if we come back in and we'll kick off again at 10:50, and I would ask the panellists for the next session to come up and be up here right at the start of that, which is now moving into that government sector. So thank you very much and enjoy your coffee. Okay, moving in, if I could have the panellists for the next session up here on the stadium podium. Yes, Michael, you have to sit on the red couch.
Yeah, can we do that?
Well organised. So we might let people filter back in, but we are going to start because obviously this is a very good session and we really want to keep the focus on the topic, which is really working through what we need to look to do to get the best outcomes for this health service in this place with the current framework that's on the table, but what can be better into the future. And as we move to this next session, we've got people who put their hands up, except for David, put their hands up to represent their community. Tough gig, a really tough gig, but they are there 24/7, and we really appreciate the time that you have taken to be here. So I'd like to welcome first Member for Indi, Dr. Helen Haynes, who's facilitating the session. Then the panellists are the Honourable Jed Kearney, Assistant Minister for Health and Aged Care. We've got the New South Wales Parliamentary Secretary for Health, Dr. Michael Holland, who's my local member, I might add there. The Victorian Shadow Minister for Health, Georgie Crozier, and the New South Wales Greens MLC, Dr. Amanda Cohen, as well as David Clancy back. We're going to go through a process today with the session. I'll then pop up again for Q&A, and then we're moving into a final facilitated session. So, panellists, over to you.
Well, thank you very much, Leanne. And a very, very warm good morning to each and every one of you, and a big thank you to Councillor Ron Mildren, councillors and Wodonga City for facilitating this really important health forum here on the border. This session, as Leanne has told you, is called Government Perspectives, Navigating Public Health Challenges. And it's our chance to hear from two levels of government, state and federal, and a clinician, of course, with David down there, and to really explore health funding, the policy space of health, and what means we have collectively to advocate for further investment and better health outcomes in our region. I'm really proud to moderate this session today, where sometimes we talk about bringing people together across the political divide. I prefer always to say that we're bringing people together across a spectrum of ideas and ways to solve a problem that we all recognise as a problem. So I'm really proud to be doing this today. I'm also, I think I can't help but observe how many former health professionals are now members of Parliament on this panel. And I reckon that tells you something. And when I hear the passionate voice of Dr. Clancy, I know that as health professionals, there comes a point in our life where we realise we have to do something about the policy. We have to do something at a political level. Perhaps we need to put up our hand for public life. So I think it's a very interesting panel that we have here today, and one with real lived experience. So the way that this session will work is that each of our panel members will make a short statement with a focus on explaining how their level of government contributes to health funding and how that interacts with other levels of government and policy more broadly. So we've got a large panel, and rather than go through everybody's CVs now, I'm just going to introduce people briefly prior to them making their statements. So I want to start firstly with our Assistant Minister for Health and Aged Care at the federal level, the Honourable Jed Kearney, and I'm very grateful to Assistant Minister Kearney for making the trip here today and representing the federal government.
And prior to being elected as the member for Cooper in 2018, Jed was president of the Australian Council of Trade Unions, and like me and like Georgie, she started her career as a nurse. There is much to her CV. I do encourage you to look it up at some point, but I invite Jed now just to say a few words to us all. Thank you, Jed.
Thanks, Helen. Oh, it works by itself, magic. Look, thanks so much for having me. I really appreciate the invitation to come down, and it is wonderful to have another nurse in Parliament, Helen, and we work together so well. It's really lovely. Helen's office is just around the corner as well, which makes it very easy for me in Parliament. Welcome to all the other panellists. Thank you for your time. I guess I would start by opening remarks. I'm sure you've already done this, but I too acknowledge the traditional owners of the land on which we're gathered today and pay my respects to elders past and present. And it's great to have the opportunity to talk with you all today. I thought that from a federal perspective, I might just give a quick overview of where we see our priorities of the federal government. We have put health front and centre of the federal government's list of priorities, to the point where we have 5 health ministers in the health portfolio. We have Mark Butler, who is the Senior Health Minister. We have Melandiri McCarthy, who is the first ever First Nations, Assistant Minister for First Nations Health. Annika Wells, who's the Minister for Aged Care. Emma McBride, who is the Assistant Minister for Rural and Regional Health. So, you know, she's always someone that you can turn to. She's also the Assistant Minister for Suicide Prevention and Mental Health. And we have myself, who's a little bit of a dog's body, if you like. I'm Assistant Minister for all of those things across all of those areas. But mostly for my own interest, I have a particular, doing a particular body of work around women's health, migrant health, and LGBTIQA+ healthcare. So they're the areas that I'm working on myself. This is a Labor government that is really committed to, bolstering and boosting the health system over what we see as a decade or so of lack of investment. So from the federal perspective, our main purview, as you know, is primary health care. And I know that there's lots of discussions about hospitals here today, and particularly a tertiary centre for this region. But we are blessed with a federation, and as such, a lot of our policy areas have been split between the two. The federal system is very much focused on primary healthcare. That's not to say that we are not interested in the hospital system. We are very much, and we work very closely with our state colleagues, state and territory colleagues, on making sure we have an excellent tertiary healthcare system. We are responsible, as you would know, mostly for funding Medicare. We have made record investment in Medicare. We have tripled bulk billing investments for our GPs. We have invested millions and millions of dollars in cheaper medicines. Any of these I can go through in more detail, but I'm conscious of time. Cheaper medicines. We really invested heavily in aged care, because we know if we keep people well in their homes and in residential aged care facilities, they take a lot of pressure off the healthcare system. We have stood up urgent care clinics right around the country, and I know there's one here in Albury Wodonga, which is taking pressure off the tertiary health system by keeping people out of ED. And I just to give it a little bit of local context, because Helen asked me to do that, I did have some figures here. Through our cheaper medicines program, for example, we've delivered a savings of $1.287 million to the people of Indi. And for the people of Farrer, just over the border, $1.584 million has been saved by your good constituents with our cheaper medicine policies. So that is, of course, through reducing the cost of scripts. We did the first ever reduction on the PBS subsidy from $42 to $30, and we now have our 60-day prescribing, where you can get double the scripts for the price of one, which of course takes pressure off our wonderful GPs. You don't have to go to the GP so often, and it is much cheaper. Thanks to our bulk billing incentives, there has been
a massive increase, in one of the largest increases in the country, actually, in Indi, in bulk billing, which I'm sure you'll be pleased to know. I think it's about a 6% increase in bulk billing rates, thanks to the tripling of the bulk billing incentive and other incentives that we're giving GPs. And across the border in Farah, there's been a 5.3% increase. Now, that's all much higher than the national average, which is 2%. So a lot of our policies are really delivering for rural and regional areas, which is really wonderful. And finally, one of the other areas where we negotiate and work very closely with our states is through the National Hospital Reform Agreements, or commonly known as the NHRA, which is set to be reviewed very soon. There are negotiations coming up very soon, and of course this sets out the financial arrangements and governance between the states and the Commonwealth with respect to funding pretty much mostly the services that the states provide and the Commonwealth contribution to that. So there's lots of other areas. We've introduced, our vaping reforms, I think, which are going to have a great impact on the health of the nation. We've invested very heavily in First Nations healthcare, mostly across the centre of Australia and in the Northern Territory. So really the focus has been rejuvenating primary healthcare and keeping people well and out of hospitals. So I just thought I'd start off with that, Helen.
That's great, Jed. Thank you very much for that overview. And can I also acknowledge in the room, we have many members of our local governments, mayors, CEOs. We have other members of Parliament here too, and I want to acknowledge that the Honourable Susan Lee was here this morning. We've got the Honourable Justin Clancy and the Honourable Tim McCurdy here. So great representation here, and many members of the public, hello to you. Thank you so much for being and participating in this really important conversation. Our next panellist is Dr. Michael Holland, and Michael is the Parliamentary Secretary for Health and Regional Health in the New South Wales Government. And prior to being elected as the member for Bega in 2022, Michael worked as an obstetrician and gynaecologist in the Bega and Eurobodalla Shires for close to 2 decades. Gosh, you mustn't have had much sleep, Michael. And he was a senior specialist at Maruya and Batemans Bay hospitals, and both Georgie and I are former midwives, so I'm sure we could all swap a few stories at lunchtime. Michael, could you give us some introductory comments, please, from your perspective at the New South Wales State Government level?
Thanks, Helen. It's remarkable, the panel that we have here, that people clinically have made that transition, in my case, an unusual transition to retirement, I keep calling it. But, and you find this in health all the time, really, in health departments, ministries. Most of the people that are employed there have health backgrounds, and that's a great thing to have. It's not like having an educational system that's not supported by teachers. So, I don't want to run off a great list of achievements and plans. We're into only this month, our first 12 months of government. We've had policies and directions that we follow, and one of the first directions that we follow is that you can't run hospitals or a healthcare system without healthcare workers. So one of the first things we did was to remove the wages cap for all healthcare workers, which has benefited our health service workers, our nurses, our allied health, our midwives, and particularly our paramedics. That will help retain and recruit more healthcare workers to the state, because there was an efflux of people going into state because of the previous conditions. That's supported also by recruitment at the entry level, and that is offering scholarships to trainees, both in any health form, whether it's medical, nursing, midwifery or paramedics, and also doubling the subsidies to go to healthcare workers to move or stay in rural and regional areas. Now, rural and regional areas are very important personally. That's basically how I got here, as a consequence of the the Upper House inquiry, Legislative Council inquiry into rural and remote and regional healthcare and hospital access. Our government you see so many inquiries that have a list of findings and recommendations, and then you look at implementation, that's where it falls down. So our first priority is to look at implementation of all the 44 recommendations of that inquiry. I look forward to that being delivered later this year. We're also looking at a special inquiry into healthcare funding. That's made certain organisations nervous, but without data you don't know really what's going on in our field. Again, there's been a lot of discussion about health infrastructure, and there is that term that was used, I think, before, build it and they will come. Not always the case, but the impression that I've had today and the message that I've got is primarily the message about services that you're needing in the area, how that's going to be funded. And I think on a personal experience in my own electorate, we had 2 small hospitals in one half of one shire that need to merge to give a level 4 hospital. And despite parochialism in both areas, ultimately, as generations changed, people decided it's not about the site, it's about the services. And once again, you can't have the services without the staff to run those services. So there's been a lot of work on dealing with the bigger hospital system, and I think the time's changed quite a bit now in terms of this division. And it's great to see local government, state governments and federal government cooperating. And I think the lines between those boundaries have really started to be less clear, particularly the help that we've had with urgent care clinics. So we've looked at the crisis really that we've had in hospitals and emergency departments to, I've seen the analogy of the overcrowded emergency department is the overflowing sink. Well, what do? Well, you stop one way of the flow into the sink, but you also have to unblock the drain that's going out of the sink. So we've looked at and achieved something like 175,000 potential presentations to the emergency department by the use of various virtual care models that are available. The government's very keen on a number of virtual care models. It's also very keen on innovative clinical models where talking about capability of other health professionals being increased, what paramedics will be able to do on the way to hospital. We've also had a task force to reduce the surgical wait list. So I think we've achieved a lot in the first 12 months. I think we'll probably get on to some discussion about some of these other models as we go along.
Thank you very much, Michael. Next, could I introduce the Honourable Georgie Crozier, the Shadow Minister for Health and Ambulance Services in Victoria. And as I mentioned at the outset, Georgie is also a former nurse, midwife, diabetes educator and hospital supervisor, amongst many other things, of course, Georgie. And I invite you to make some opening statements, please. Thank you.
Thank you very much, Helen, and to my fellow panellists. It's great to be able to join you this morning. But can I also thank the Ron Mildren and the Council and all of those that have put this summit together. It is a really important forum that you're having here, bringing stakeholders and the community into the room to discuss these issues. I'd also like to just acknowledge my parliamentary colleagues here, Helen, my upper house parliamentary colleagues, the Honourable Wendy Lovell and Gail Broad, who are also here listening to you. And I think that's incredibly important that we as politicians need to do, is listen to the community. Certainly, listening to the panellists this morning, as I said previously, there's a lot of passion, there's a lot of concern, and there's a lot of good ideas that have come out of this morning's discussion, so thank you. David, I've been up here a few times. I've come up to Albury Wodonga, and I've met with you on a number of occasions, both in person and via Zoom, talking about this issue over too many years now. My colleague Bill Tilley and I have been raising these issues time and time again in the Parliament. We've been asking for documents to be released by the Victorian Government. They've never been forthcoming. So congratulations to you, Amanda, for getting the documents from the New South Wales Government. We're still waiting on documents in Victoria. We're still waiting for questions to be answered around what the government actually plans to do. It is a complex situation. You've all highlighted that this morning. But it doesn't need to be, as you've highlighted, it's about the needs of the community. And I'm not in government, so I can't make the decisions, but I can continue to push and advocate on behalf of this community and communities right across Victoria about getting better access and having better utilisation of taxpayer money. And really that's what government is for. I mean, Helen asked about the opening remarks about funding. Well, health is expensive, it's complex, and there is multi-layers of funding and it can be very rigid. But it's up to government to negotiate that and work through it, both at a federal level and a state level, to be able to deliver the outcomes for their community. That's what government is there for. It is there to represent you and to provide the best services it possibly can on behalf of you. I don't believe that's been done in this community. Bill doesn't believe that's been done, and that's why we've been having summits up here, listening to patients, listening to the clinicians, and wanting to provide a solution. We took a solution in 2022 to the election. We weren't successful. But we wanted to put something to the community that gave them an opportunity to look at what needs to be done. And I think out of today's discussion, we've seen more of that evolve. So let's look at what you've all been saying today, and it's just a pity that there is no representative from the Victorian government here to hear from you, to work through that in a way. As David said, there's a white blank page there. Let's work on it. Let's get this solved, and I think that's what needs to be done. So I just leave it at that, Helen, and say thank you again for being here, for holding this, for everyone to be here, for holding this important forum, and we'll continue to push to get a solution that meets the needs of this growing and very, very worthy community.
Thank you very much. Thank you very much, Georgie. Next, I'd like to introduce Dr. Amanda Conn, who probably doesn't need too much introduction in this place, but Amanda is a member of the Legislative Council in New South Wales. She's the Greens spokesperson for health. Prior to entering Parliament, Dr. Conn was a GP here on the border and was also an Albury City Councillor. So she brings multiple perspectives to this. And could I ask you to make some opening remarks, please, Amanda? And thank you so much for being here.
Thank you, Helen. And I echo the earlier comments about how wonderful it is that we actually are all in this room having this really important conversation. Today, it's a real pleasure to be here, and I commend Wodonga Council for pulling us all together. I was only elected to the New South Wales Parliament last year. I'm a member of the Upper House, which means that I actually represent the whole of New South Wales, even though I'm still living here in Albury. And I have a really exciting role, which is being chair of the Legislative Council Committee for Health, which gives me the opportunity to ask really tough questions of the Health Minister and the Health Department. It gives me an opportunity to lead inquiries. And as you all know, I've had some success in releasing documents out of the New South Wales Government. And I think, as we talk about the different levels of government and government processes today, it's really important to acknowledge that that's not just because I'm asking really clever questions. It's because we have minority government in New South Wales, and the crossbench holds the balance of power in the Upper House. And so as a crossbencher, particularly in the Upper House, I'm able to actually put those force those documents to be released through the Parliament. And it's only because of that unique political situation that we've got in New South Wales that that's been possible. I think it's a really important demonstration of actually the power of the crossbench and the power of minor parties in driving change. And I'm somebody that is never going to be the health minister. To be honest, I don't want to be the health minister. My role is really about accountability, it's about transparency, and it's about making sure the government of the day, no matter which party is in power, is actually held accountable for the decisions that they make and can explain those properly to the community. So the elephant in the room today is obviously the hospital and hospital infrastructure, and that's what people want to talk about. And an interesting thing that's happened is since I started asking hard questions about Albury Hospital in the Parliament, I've been flooded with testimony and information from other people across the state and other communities who are actually facing similar challenges. And then some examples I could give would be Grafton Base Hospital, Manning Base Hospital, and there's these communities that feel really frustrated that they're getting these investments in regional infrastructure that just don't meet the needs of communities. People are really frustrated and trying to understand how on earth this is happening. And what I can see has been happening, what the pattern is that a decision is made at a political level for a variety of reasons, and a certain amount of money gets allocated. So for us, that was 2022. Here in Albury Wodonga, both premiers came and they made an announcement, and that sort of locked this figure in stone. And what happens is they can't actually deliver the services that we need within that funding envelope. And it's something that we've just had confirmed through that budget estimates process, through the documents that got released yesterday, that they are trying to build whatever they can out of the funding allocation. It's not that the funding allocation actually meets what the community needs here in Wodonga. And that's how we're ending up with this ridiculous situation where we've got the same number of ICU beds we've got now, where we currently have space for a second cath lab, but the new hospital's not going to have space for a second cath lab. It's this reduction of scope. But the worst part isn't just that, it's that they're not upfront with the community about what they're doing. They don't explain that that's what they're doing. The government and the department actually gaslight the community by saying that's what you've sort of deserved all along. This is why the 2021 master plan was never actually released to the public, because what's happened since then is they keep trying to revise the numbers down, and Dave Clancy in his presentation pointed this out really beautifully, that they try to revise it and say, oh, well, you never needed that many beds to begin with. We'll go from a 15-year horizon to a 10-year horizon. We'll change the algorithm to try to pretend that you're getting what you always needed. And I think that's the bit, to me, that is completely unacceptable. The government really needs to be honest with this community that we are not getting what we need. We are getting whatever they can fit within a funding envelope. And the more and more challenges that we're seeing with that, as they're trying to actually organise this redevelopment of Albury Hospital, there's more and more challenges with making that fit. The cost is blowing out further and further. The process is going to take longer and longer. Through that process, we really now need to revisit the alternative, which was a greenfield site, which was what was recommended by the 2021 master plan, and that's my view. And if I can just have one more minute, we had such a good discussion this morning about health workforce, which is obviously critical, right? A hospital is just a building without staff. But the impact that this infrastructure problem is having on staff here in Albury Wodonga is profound. I've spoken to nurses about how they feel about the prospect of working in a construction site for potentially more than a decade, of working in a hospital where just stage 1 has been finished and bits of stage 2 are meant to be somewhere else, but we don't know when that will be funded. This is bad for morale, and people are leaving, and we've seen that happen in other parts of New South Wales. Manning Base Hospital is stuck between stage 1 and stage 2 of a staged brownfield redevelopment, and they can't recruit and retain staff. So coming back to that excellent panel that we had this morning about retention actually being your best strategy, actually getting the infrastructure right now for Albury Wodonga is absolutely critical for our staff, and it benefits GPs as well. I was a GP. I know that GPs, especially of a younger generation who want that portfolio career, who want that work-life balance, they want to work in a town where they know if their patient gets sick after hours, will actually be looked after in hospital. They want to know that they can refer to specialists who have expertise at their local hospital. So getting the hospital right is actually going to shape the future of the rest of the health system. That's what we have to do.
Thank you very much, Amanda. Our last panellist, and I'm conscious that we want to move on to some questions. And David, I know you are very well known to this group. I really don't need to give you any introduction, but I'm offering you the chance of maybe a word or two, or if you would prefer us to go straight into the question section, I'm happy to do that too. I'm in your hands on that.
Thanks, Helen, but I would have thought that you'd learned not to give me a microphone.
I was a bit nervous about maybe.
That's all right. Look, I really do appreciate the panel that's been assembled. I was a bit curious as to why I'm sitting up here, but I'm listening to some of the responses and understanding a little bit about it. And Amanda has been, you don't need to add much to Amanda, but I would just make the couple of points here that just from some of the responses that you hear when we talk about policy, I actually hear politics. And I think that that's what we need to hold each other to account in this room. Are we really looking at that blank canvas? When I hear about federation, we all sneer at the Americans who are beholden to guns because of a constitution that was written when you had to reload a musket over 45 seconds. And yet we're already starting to draw lines based on a federation that was developed by a round table of greybeards in the 1890s. Let's break down the barriers. Let's make sure we hold each other to account. And also when we talk about policies and we talk about things that we see as successes at a political level or a department level, let's take in the grassroots feel and the local experience. When I hear about urgent care centres and primary care networks, primary partnership networks, or whichever acronym you want, the real experience is there hasn't been a reduction in emergency presentations at Albury Wodonga Health. The real experience from the GPs, and you can ask Jodie Colbert in Wagga, operating a general practice, you lose your GPs from your GP centre. Why? Because they get offered locum rates to work in an urgent care centre. Don't create more problems with your solutions. So let's hold each other to account and let's have the blank canvas.
Thank you very much, David. And all right, I'd like to just move across the panel with some questions that we can explore, taking on board all of the experiences and experience that we have on the panel, and to take up that challenge of a blank canvas and about working together. Notwithstanding, we do have some challenges of federation, David, but we have a constitution. We're a bit stuck with that at present. So we do have to work within the constraints of our federation. But I think we can, and I'm really up for it. So I'd like to start with you, Michael, if I could, please. Michael, we've been speaking a lot, of course, this morning about our biggest infrastructure challenge, which is achieving a single-site hospital that's fit for purpose right into the future, taking on board our growing population, absolutely putting the people of this region at the centre of that, and critically understanding what our healthcare professionals need to thrive, to be the best they can be, and to be retained with their experience and expertise in the region. So we've talked a bit about planning. We've seen documents. There's a lot in the press. There's a lot in the Parliament. Can you just speak to us a little bit, please, about how does the community and how do you see the community having confidence that robust planning and data analysis actually inform funding allocations, service direction for health services, and particularly in areas such as ours where there's significant population growth?
Thanks, Helen. Hospital development, how you build a hospital goes through those phases of planning, design and delivery. And I think what's not reflected in certainly how these decisions are made, there's been a number of references to clinical services plan, and there's always a number of iterations of that when you're developing a new hospital. Now, the clinical services plans do not necessarily refer to the financial planning around that. It moves on then into the master plan. Then you go on to a functional brief and then the business plan with that. And I think and congratulations to Amanda, and she's doing her job for what she's doing. It shouldn't have to be a Watergate type of experience to get this information. And I think many of us are here, yourself included, where we've come into our representation role through people being dissatisfied with transparency and accountability. So we're all representatives of our community, and the thing we always have to remember, both clinically and politically, is that it's the people, it's the patients that we and our constituents that we represent to do this. So I had the experience, once again, through various iterations locally of clinical services plans in the Bega electorate, where people said, you know, and a common thing you've probably all heard in your electorates, we weren't informed. And I think there's a great failure in whether it's public relations in government or communication, where the community isn't directly informed. And credit to everyone here in this room, you're asking the questions. So that's the first thing about transparency and accountability, is to have good advocates that ask the questions. And the answers are there. So as a government, we are responsible for providing that. It gives people faith in government, and that's been a problem with government. And I mean, I don't like to talk about politics. I'm not a born politician. I think we have a responsibility to have good government. And so that good government is whether you're in opposition, you're part of good government, to make that our government accountable for what we do. So as I said, this whole venue, this whole symposium that we've got is related to that transparency and accountability, to be asking the questions and to expect those answers.
Thanks very much, Michael. I'm wondering, Georgie, if you might respond to this too. And we are talking about fundamental transparency, accountability, trust in government, around data informing policy, about data informing funding, and we've had a change of government in New South Wales. So, you know, does the data, does the need actually translate across borders and across various governments? Would you mind having a go at that one, please?
Yeah. No, it's terribly important that you can inform your decisions based on data. I think we all agree to that, and I think governments at all levels would agree to that. Michael spoke of, to have good government, you need good opposition. And it is true, you do. But there is a responsibility for us in opposition to be asking the questions, as you would expect, or the community would expect us to ask government. But there is also a responsibility of government to be truthful and transparent. And we're not getting that. And we're not getting that in Victoria when they don't release the data, when they don't release the documents, when they don't release the information. And I know that both my state and federal counterparts, we have been putting FOIs in, we have been asking through the Parliament for this information that we're discussing today, and we've got nothing. Nothing. So it goes two ways. You know, when you say hold governments to account, well, when oppositions do that, you expect governments to do exactly what is expected that the community wants, you to release that information. So it is totally imperative that you have transparency, that you have data release that can be worked on, and that you can then learn from it. I mean, we were talking about COVID before, and Helen and I were having the conversation at the table. You know, I've been saying, well, we really do, need an inquiry into the Royal Commission. I've been asking that since 2019, because you've got to learn from your mistakes so we don't go back there. There were good things out of that, there were bad things out of that, and this community knows only too well the complicating factors between two governments that were operating. So there is an absolute critical need for transparency and governments to be open, and so that they can have the trust of the community. And I think, unfortunately, that trust is waning across community across the board because of the lack of transparency, and in many situations where people have not been told the truth by government. We need to do better.
Okay, thank you, Georgie, and yeah, I would agree with the comment. You know, we don't need to have Watergate, really, do we? I think that transparency, accountability, clarity of data, follow through, understanding, and I think in so many ways communities, whether they're regional or metropolitan, are not unreasonable in asking for that and in seeing a line of sight between need and decision making. So I'm keen to explore then, given that we've got different levels of government here, and I want to ask you, Jed, how can different levels of government collaborate effectively to address healthcare challenges? And if you're able, and I know this is not your hometown and that you're at the federal level, but how can levels of government collaborate here in Albury Wodonga and our broader region, knowing that our footprint is in excess of 300,000 people? We are the busiest health service outside of Barwon Health, and you could argue Geelong's actually a city now. It's far from a country town. So we have a huge challenge, and we're cross-border, and you can see today that local government is collaborating and that we have our state and federal here. How can we do this better, and what insights could you give us, please?
Sure. Thanks, Helen. Well, you're doing it, as you say, right now. This is fantastic. It's really exciting to have all levels of government here today talking about this, and to have the community, to have people with the lived experience of the system sitting here and feeding back to us as policymakers right across the three levels of government about that. So this is a brilliant example of what we can do to make things work better. From my perspective, at a federal level, I think that conversation about data is incredibly important, and this is one of the areas where we could do better across the Federation, I think, is share data. It's very difficult. Our systems don't talk to each other, as you know. It's really very difficult to get information about a patient across hospital to hospital, let alone from GP to hospital and vice versa. Some systems in this country are still using faxes, which is extraordinary. And so, you know, for the federal level, this is a big issue for us, and we would love to have really good seamless national data so that we can really improve that journey for the patient wherever or whatever level of healthcare they are accessing. We are investing record numbers at a federal level in a digital health system. For the first time ever, really, we've got the digital blueprint. My Health Record has been taken up in massive way, and I think it's really thanks to COVID that people are starting to really trust that digital keeping of data at hand at digital level. There's something like, oh gosh, maybe don't quote me on this, but there's something like 21 million now My Health Records in Australia that are being actively used, and since we have a population of 27 million, that's pretty good. So Australians are really embracing that. So yes, data I think is incredibly important. I agree with you, Michael. And you can't know what you don't know. So and having the ability to analyse that data and working with the states and local governments to share that so that we can have a seamless system for people who use our system, which at the end of the day is why we're here. We're here for people who use our health system. You know, we do have a federation, Helen, you're quite right, and we are constrained by that, but we spend a great deal of our time trying to find workarounds about that. So really, you know, the urgent care clinics and one of those perfect examples, and Michael, you raised it, of where we work so closely with the states to try to cut that divide between what is traditionally seen as a federal purview and a state purview. The urgent care clinic here in Albury Wodonga has seen 2,000 patients since it opened, and 1 in 4 of those patients have been kids, young people. And the feedback that we're getting from your community is that that is so great. They're not sitting for hours on end in the ED, clogging up ED. They can't, you know, they're having trouble getting into the GPs. GPs don't have to worry about not seeing those urgent things, but they've still got that main connection with their GP and their primary healthcare provider. So, you know, this is a prime example, I think. What the other things that we're trying to do is really, as I said before, really pump money into primary healthcare to take the pressure off the hospital system. Our screening, we just invested billions of dollars in making sure there's, you know, lung screening, for example. We've expanded bowel cancer screening. We have mobile breast clinic screenings that are funded by the federal government in trucks going around, cardiac screening that we've invested a lot of money in that. So we're really trying to work with the states to say to the states, well, and the territories, of course, because each one has their own specific needs, and we do use the PHNs a lot for this. You know, how can we work with you to sort of break that artificial divide that is the federation, but something that we are really tied with. So we're trying to be innovative about that. We have all of these trials happening at a moment around innovative models of care, and I'd really love to hear from you, maybe, Helen, and your community, if anyone is doing things really, really well here. We've got a lot of pilots going on. I haven't got time to really tell you all about them, but if anyone's interested, I'm really willing
We
to
won't
talk
get
about them.
back to you on that one, Jed.
You'll come back to me on it one time, but there's really exciting things happening to really, because we're talking to patients, we're talking to people who use the system, who are telling us they don't want to wait in ED, they can't see a GP, they just want, care when they need it and that they need it. Things like the National Immunisation Program being given out by pharmacists now is so popular. It's so popular, and having some pharmacies now being able to prescribe for simple medications like UTIs, antibiotics for UTIs, etc., is a game changer. We've just, there's so much that's happening right across the federal sphere, state sphere, because as you know, states control the medicines regulations, so we're having to work very closely with them around prescribing, etc., and right down to local levels of government who provide things like Community Health Service Program, the CHIS program for aged care recipients. So we are doing a lot, Helen. We're really working hard on breaking down this divide and trying to make the system as seamless as possible. We've only been going 18 months. Very proud of what we've done so far. A lot more to do.
Thank you, Jed. And I think that we all understand in this room how complex health is, how many components there are. We heard this morning about rural health workforce. We heard about the potential role the federal government can play in investing in a rural health education and research collaborative centre, so that we build that pipeline, that we're not only getting people into health careers, but we're keeping them, and that we're building the mid-career opportunities for people to continue to train and remain as specialists here. But I am concerned by this disconnect when we know we have data that builds a very powerful case here on the border for a bigger investment into the infrastructure that we need to achieve all of those things. And I'm just wondering if possibly, maybe you, Amanda, might just want to comment on the disconnect when we have data, and you've found it, and many people in this room contributed to putting forward a business cases built on solid clinical service planning in good faith, and just wondering what more we've got to do and what you might say about that.
We've already talked today about the 2021 master plan. It's a beautiful document. It shouldn't have taken the amount of work that it did to be made public, and what it really felt like with that reluctance to release information was this need to defend the decision that was made at all costs, rather than actually engage in a mature discussion about what happened and what we need moving forward. And in terms of that accountability, it shouldn't take a very cranky upper house crossbencher to keep releasing documents to make that happen. This is not a good process. What I would really hope is that the government can actually come to the table and have a mature discussion with the community here, but also that we can just take some of the politics out of this. The decision that was made in 2022... Thank you. The decision that was made in 2022 was announced by a Victorian Labor Premier and a New South Wales Liberal Premier. They're not in government anymore. We've got an independent federal member, a Liberal federal member, and all this information's been pulled out by the Greens. Like, we're all here. Everyone's had a role to play in the mess that got us here. We all have a role to play in fixing the mess. And I just hope that actually if we can have that kind of mature, respectful and solution-focused conversation, there would be less of that fear and that defensiveness, whether it's coming from the department or coming from the ministry. There's this sense that if anybody knows anything about any decisions that were made, if any data gets out, we'll get hammered. I think, I'm quite inspired by Dr. Clancy's invitation this morning to look at this as a blank slate and a blank page. We're all here. Let's take the sledging out of it and actually fix the problem.
Thanks, Amanda. And I think, David, you look like you're keen to respond to that.
Sorry, Helen, but Amanda, please, no one calls me Dr. Clancy. Mum and Dad called me David, and that's good enough. Data. There's two accountants that I'm looking at that are probably salivating at the word of it. Just because you can look at an Excel spreadsheet doesn't make you understand. Michael? Yes, there's reiterations of a clinical services plan. The one that we're passionate about is the one where the data was put in front of the subject matter experts to tell you what the problem was. And that's the difference here. Data's been used in subsequent iterations, but the lens of the community and the subject matter experts wasn't. To the question of can the community be confident based on the data provided when making decisions? No. You know why? Because your IT infrastructure was not resolved at the 2009 merger of Albury and Wodonga hospitals. Bottom line. Give you a couple of examples. And if people want to say that clinicians shouldn't be involved in these decisions, these are facts that were developed and found by clinicians. So in terms of planning for clinic spaces, and we talk about primary care and we talk about community care, okay, so when we're talking about infrastructure, we're not just talking about acute hospital beds. Please don't get that wrong. When it came to the data for ambulatory care services, understand this. It was put in front of clinicians too late. They said, it's not right. We already have that. No. That's it. Now, this comes from a clinician that works at Albury Wodonga Health who told me this. They went, well, hang on, how do you calculate that? Oh, it's very easy. What we do is we look at your administration system and we count up how many patients you saw, how long it took to see them each. Right, great. Go back to the source. How does it work? The IT infrastructure is so antiquated that many of those patient episodes, those presentations, despite taking 30 minutes, 45 minutes, 60 minutes, 90, they're inserted into a computer system that says 1 minute.
David,
Okay.
can I stop you there? Because I reckon this is pretty complicated stuff.
Yeah.
And I think you're making the point very clearly that our systems aren't speaking with each other in a way that truly represents what's going on. And I'm wondering how we can get to this blank canvas point that you talked about earlier, in which I know we've got a group of people here who want this to work ultimately. Yep. And I'm wondering, maybe, Georgie, you've been in state government for a while. How can we make this intergovernmental agreements work better? Have you got any thoughts on that? I'm sure you've been thinking about this a lot from opposition. What can we do better on this?
We need to do better, Helen. I mean, this is, as everyone said, it's a complex situation because it does have the cross-border issues. However, as David has pointed out, take out the river and you're looking at a community, you shouldn't have that complication. So that's really where government has a responsibility here, both all governments, Victorian, New South Wales, obviously, because they are in this agreement. You know, it's up to them to come together and really work with what David is talking about, what Amanda is talking about in relation to the data, what is there, the master plan that has been there that we've been calling on the release for years on. Have a look at that. What do we need to be doing? And where is government? I think there is a void at that state government level in this solution. So to go back, you know, they're the decision makers. Amanda can do so much, I can do so much, but they are the government and they need to be really coming to the party and speaking and having a look at that. So that governmental agreement and everything that they're discussing needs to be open. It needs to be understood by the community. They need to come to the community and explain it to you, what their plan is. That is critical. At the moment, I don't think the community has any clear indication of what the Victorian government's plan is, apart from, you know, some money that was announced by the former Premier with the former New South Wales Premier. What does that mean? Does it still stand? What does it mean to the master plan that was, or the plan that was released yesterday? I think that those two governments need to come and speak to you directly.
Thank you, Georgie. Leanne, can I ask you to come now? And I'd like to open questions to the floor. We have, I think, about 10 minutes or so.
Probably about
15? Great. All right. And I can see hands flying up everywhere, which is absolutely terrific. So,
Fabulous. The lady over here in the blue.
if you could just please introduce yourself, where you're from, and if you'd like to direct a question to anyone in particular. Hello, Di.
Thank you. Di Thomas. I'm with Better Border Health. Very, very quick. We were formed in 2022. We looked at the opportunity to work alongside the border Medical Association because we knew that this wasn't just a problem that should be left to the clinicians and the health workers, that it involved the wider community. What we've seen during our formation is it seems apparent that our health infrastructure is ad hoc and it's influenced by pork barrelling, who screams loudest, and parochialism. So our question is, we've had a lot of conversation about data. That data is available. There are mountains of data. Why do communities have to advocate so hard for baseline services and try and make this available? As David referred this morning, this is not our job. We came together as community volunteers. Sorry, am I getting emotional about this?
Yeah, we understand that.
And, so why do we have to fight so hard for what we should be expecting?
Thank you. And the passion absolutely is real when people are coming together in this situation, so we acknowledge that, and thank you for being honest about it. Anyone from the panel who would like to step in and respond to that in the first instance?
I think it's correct that you advocate. I mean, if people were silent about these things, the simple clinical services plans, master plans, all would just be accepted and roll through. So people need that advocacy. They need to ask the questions, as we've been saying before. And I suppose one of the things we've been asked about data, and it seems as though we're looking at two different sets of data. We need that good question. It's not question time in Parliament where you don't get an answer because the question is unanswerable. I would really encourage your community to ask the question and put it in writing to your representatives and expect that answer, but get the question right about what is the response that you're looking for. And look, we're all here to try and provide the best service. There's been, earlier on great discussions. I really enjoyed this morning's session earlier on. Need determines your policy. I say that all the time. So we have to look at what the need is in your community. That determines the policies that we take from there. Now, there are various iterations of clinical services plans because delivery changes according to changes of policy. That is, health systems may look at saying, well, we're going to prevent people coming into hospital, and that's, again, an important thing from a federal level and at a local level with our primary health services. So I suppose that would be my message. It is great that you do advocate and you do have the expectation to have an answer.
Are there anybody else on the panel? Amanda?
One of my favourite quotes is from Margaret Mead, who's an anthropologist, and she says, "Never doubt that a small group of committed people can change the world. Indeed, it's the only thing that ever has." And I don't think we'd even be here today without the incredible work of Better Border Health, bringing the community into this discussion. And I also wanted to commend that your group's really actually leading by example the kind of collaborative work that we need to do behind the scenes. I know that you've talked to every politician of every political stripe. I know you're working both with the Border Medical Association and the Nurses and Midwives Association, Albury Hospital branch as well. And I think that's really commendable, and we could all learn something from the way that you're doing things. Unfortunately, I think the reality is we do need volunteers. We do need the community to be talking about this loud and clear. This is an issue that impacts every single person who lives in Albury Wodonga. And they can't all be here today. So, your voice as volunteers on behalf of the community is really essential in all this moving forward.
Thank you.
Could I just make a comment too,
Yes.
Leanne? Thank you, Amanda. I agree with you entirely. Participating in your democracy is fundamental to what we need to do, and it's something I'm really proud of the community here that they are doing. So thank you for that. It's critical. It's critical for community to raise the voice of the people and to highlight detailed case studies of the why. I think you're absolutely right, Di, though. The next part of that really long-term, hard data analysis kind of work isn't the work that communities should have to do. So I acknowledge that as well. And to your point about pork barrelling, I want to pick that up because I've been talking a lot about that issue this week. We need to have fair and transparent infrastructure pipelines that are clear for everyone to see where they are in the queue, based on solid planning, and I want to commend the work of the Rural Health Alliance on constantly calling for rural health plans that acknowledge that rural and regional and remote communities have poorer health outcomes than our metropolitan counterparts, and far less spending and far poorer infrastructure. And we understand the tyranny of the distance, of course we do. But we want to see equity and fairness when it comes to funding, and we don't want to find out that a community in one part of the nation who may well have very, very clear needs for infrastructure are preferenced above another community, whether it's ours or anyone else's, based on a political imperative rather than really solid data that we've talked a lot about, and a transparent pipeline of how our public funds are expended so that we can see that. So I would just add that. These things really matter.
Thank you, and I go back to...
I'll be really quick. Thank you, Amanda and Michael and Helen. That Margaret Mead comment is actually a favourite of my former employer, Cathy McGowan, who's here somewhere too. So have heard it umpteen dozen times and agree wholeheartedly. Just with Better Border Health, I suppose one of the difficulties, I want to commend all the members of Better Border Health. We come from a broad church. We are accountants, we are community leaders, we're people involved in health, previously involved in the health service. We come very broad across the community. People with a lot of expertise and who have worked really hard with the wonderful leadership of Border Medical Association. So I commend all of those people involved in that. It's been really hard because, as I say, it is voluntary. People have other parts of their lives, as everybody in this room does. So I commend them for that. But I also want to say that it's hard to keep going when, in trying to get our questions answered, we are accused of being ungrateful and we're accused of potentially damaging the community. We're not asking these questions because we want to damage our community. And so I just really wanted to make a point for that. And also, we don't want to settle for second best. I don't understand why we should settle for second best. I don't understand why Albury Wodonga is earmarked as a community that should settle for second best. That's all.
Thank you for that comment. Are there any other people on the tables that wanted to ask a question and statement? And I have seen a couple of hands up in the rake seating. At the moment, the priority is for those people that are here on the round tables, but I will get to you if we've got time in the process. So I've got Frank from Albury Wodonga and Ron from Albury and from Wodonga. So, Frank.
Thanks, Leanne, and thanks to Wodonga City for organising the event today. Frank Zachnich, CEO at Albury City. So a question for our federal representative. Albury Wodonga is, in fact, if only, the only cross-border health service we have in Australia and potentially internationally in terms of this sort of model. What role does the federal government have in facilitating that collaboration in a real sense? We've had a couple of goes at this through the regional deal model, which was had its benefits, but didn't really deliver the game-changing sort of aspirations that the community had at the time. What role does the federal government have in bringing the two states, the two cities and one community together to really recognise the importance of this collaboration, work through the key sort of complex issues that we've touched on today in this cross-border setting, which, as I said, is quite unique. And, you know, if this was easy, everyone will be doing it, but what is the approach that the federal government could take in support of this initiative?
Minister?
Thanks, Frank. Maybe I'll start with that, Jed, and then I'll hand to you as the federal well, you're representing the federal government.
You're the member.
Did you mean it to me, Frank, or to Jed, or both? Well, I'll go first because I'm kind of right in the middle of this. So I'm really grateful for your question. And as the federal representative of Indi going to government, and I've been to both governments now, and tried to make the case that this is a unique situation that we have here, and it was quite a groundbreaking agreement that ever happened, that Albury Wodonga Health came together in the first place, and it took enormous effort and vision, I can remember it, and a lot of trepidation that we would end up in a situation that didn't serve anyone well, when in essence the goal was to serve everybody better. So there was that bold goal right at the beginning, and where we're at now is we're seeing problems with that. Because we've outgrown the infrastructure that we have. We clearly have challenges with our population growth and the need to service that right through preventative health. And Susie's gone, and I'm with her on championing, Jed, hear loud and clear please, we don't get enough federal funding into preventative health so that we stay well and don't move along the pipeline. I know you believe this too. It's that as well. But I think what I hear when I go to the federal government, whether it be a coalition government or a Labor government, is where does the federal government's remit begin and end? And it is in primary health care, it is in the preventative health space, and it is in intergovernmental agreements when it comes to how much money comes from the feds into the state governments to spend on their infrastructure, if that makes sense. I'm seeing you nodding, so it does. So for me, I think having Assistant Minister Carney here today was a way of me trying to broker the federal government understanding what's happening between two state governments, and also understanding what role can they play when it comes to National Cabinet to try and resolve the tensions that we're experiencing. So I'll hand it to Jed at that point, but I guess the other thing I would say is just one more plug. One area that the federal government absolutely has a clear remit to invest in is education, training and research of rural health professionals. I'm putting a lot of effort into that at the moment, and that's where a significant investment could be made by the federal government into this whole ecosystem that is health on the border. I didn't answer your question about the regional deal, but maybe we could come back to that.
Thanks. I think you've answered it beautifully, Helen. I could say what she said, but I won't. Well, I guess adding on, the only thing that I can really add on to that is, we do have two main areas that we kind of work with the states on things like this, and I hope Michael agrees, is the NHRA and the National Health Reform Agreements, and there is a new one coming up soon. I do know in the last one, for example, there was specifically, I think, and I'm looking at my Robbie here, but I think there was about 120 million that was actually specified in the NHRA for Albury Wodonga hospital services. So it is an agreement that sort of can be specific to a degree, if you like. It's one lever. And the other, of course, is National Cabinet, where these things are discussed via the state premiers and the Prime Minister. At my level of government, I think it's about me being here, it's about hearing, it's about encouraging all that stuff I said before about data sharing, and it's about making sure that messages do get back to the federal government between the forums like this. And I know, Helen, you do that beautifully. You don't really need me to do that, but you do that. So I'm happy to hear other ways that you think, but I think this is good that we're all talking together, that all levels of government are here. Those big levers are really the main levers that we have, the National Cabinet and the NHRA. Just on workforce, very quickly, Helen, I absolutely agree with you. I have to say that when we meet as a health team at a federal level, 80% of what we talk about is workforce. Workforce, 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 workforce. We are just absolutely committed to doing as much as we can to improve the pipeline, to make sure there are education opportunities. We have several things working at the moment, inquiries. We've got the scope of practice review, which is about access. We have a brilliant health workforce that is, we have midwives, we have GPs that could be specialists and do much more under their scope of practice. We have nurse practitioners who could be doing a lot more, pharmacists who could be doing a lot more. So we're looking, Mark Cormack is doing work on scope of practice. We've got the workforce incentive program for primary healthcare services. How can we improve the workforce incentive program for GPs so that they can employ a multidisciplinary workforce and utilise them better? We've got a thin markets review going on right now where, there are places where we just can't get health professionals to go. What do we do about that? How do we sort that? And there's some marvellous trials happening very close by here right now about the thin markets. There's the CRUC review looking at the processes for overseas doctors and other health professionals and how they can register here, how we can streamline that. So there's a lot happening in workforce, Helen, and a lot more than that, but they're just a few examples of what we're working on at the moment. So, yep, workforce.
Thank you, Minister. I've got, Ron, one last question, and then we'll move into a wind-up for the session. So, Mayor Ron.
Thank you. First thing, we're still living off the legacy of the Albury Wodonga Development Corporation and the work that Minister Tom Uren did and the two state governments that were in power at the time. I think they were one of each colour from memory, I'm not sure. So that work was brilliant. We did a lot of things here that were regional and it established what we have today in terms of our social cohesiveness and our single economy. We are socially and economically one community. What we're not is we're not a single community for governance and administration. And it seems to me that many governments of all different colours over the journey have used that as a shield to duck behind whenever there's something that, they don't want to do that, or it doesn't fit an agenda, or it doesn't work. So again, I feel like what's happening today with our hospital issues, we've been distracted away from the real game, from the 2021 work that was done, which was technically correct, technically well put together, and was a really strong piece of work that would put this socially and economically cohesive community in a very strong place to go into the future. For whatever reason, politics, available resources for money, whatever, there were decisions made that in essence ignored that work. And I just don't understand why we have to put up with that. When I look back, I think the biggest failing of the decentralisation program of the 1970s was not creating a separate entity, a territory or another state by whatever means. It can be done under the Constitution and it could have been done then. It was talked about but didn't quite get there. We wouldn't be having the problems we're having today if that sort of stuff had been done. No point dwelling on spilt milk.
Ron, do you have I'm just conscious of time. If you have a question for the panel.
What I want to know and what I'd like to hear the opinion on is, how do we turn around what's been done to now? Because it's been well established up to today, and with the information that's been revealed by Dr. Con and other things that we've found and discovered about this process, how do we turn this project that's been put in place today around and bring into play all the things we've heard about today that go to make up the health service that we genuinely deserve and need? Thank you.
Thank you.
Helen? Thank you, Ron. I'm perhaps just going to direct that question, if I might, to Amanda, and then maybe to you, Michael, as the New South Wales State Government rep here. Maybe you can contribute to that answer, and then we have to make a wrap, I think,
Yes,
Leanne.
absolutely.
So,
when I was Deputy Mayor of Albury, I was Deputy to Kevin Mack, and most people in this room would know I had a whole variety of differences of opinion with him. But one of the best things he ever achieved for this community was the Two Cities, One Community partnership with Wodonga City Council, and I'll acknowledge Ron's predecessor, Anna Speedy, in that role as well. We actually need to work together and think like one community, go to both state governments like one community, go to the federal government like one community. And for as long as we're internally divided and spatting about health infrastructure, we'll never get there. And I commend your comments, Councillor Mildren, in opening the session today about needing to be agnostic about where a new hospital would go and just getting the best outcome for this community. You know, we've seen with that 2021 master plan, this extraordinary process of, you know, I've already described it as gaslighting. The Victorian government tried to say it wasn't a master plan, despite the fact that they were involved in writing it and called it a master plan the whole time. The New South Wales government is now saying they never signed off on it. And, you know, I've seen evidence of loads of briefs that were written to various decision makers that were frankly misleading. So I think if all those people actually come together now, acknowledge that the wrong decision was made based on bad information, what can we do from here and actually work together? That's the only way to get the right outcome.
Thank you, Amanda. We might hand over to Michael because I'm very conscious of needing to wrap this session up.
And Leanne, if I wouldn't mind, I'm just very conscious also that Minister Carney needs to leave.
Yes.
So I'm prepared to give her a leave pass right now if she needs to get out the door.
We are going to wind the panel up.
Are we good? All right. Fabulous. Thank you,
Look,
Michael.
I suppose my only comment is some of the expression of turning the thing around. A decision has to be made. Amanda referred to being agnostic about sites, etc. I think the thing is a decision has been made. There is $558 million to look at the infrastructure development. The site has been determined. I think we need to look at what more can be done for the community based on the need, what the clinical services and what is achievable after that. So that's, again, the role of your local political representatives here to take that to the Victorian government, the New South Wales government and the federal government.
Thank you. Helen, thank you to you and your panel. Look, it's very tough working through this process because at the end of the day, this community don't care about the border, they don't care about a river, they don't care about who's in government, they really care about the best outcomes. And it's tough to stand up here in a political engagement in terms of this discussion. It's been much appreciated. Helen, did you want to?
Thank you very much, Leanne. Michael, I think you've left us on a difficult spot there in so much as we've got more work to do now with you, with each other, and with the Victorian State Government to get the rest and to get this right. I want to thank you, though, very, very much, Michael, for coming along today, for participating in this panel discussion. It's been very, very helpful, very honest as well. Appreciate you very much. Minister Carney, Jed, thank you so much as the Federal Assistant Minister for participating in this today, giving us some perspectives of the federal role in this. Amanda Conn, Dr. Amanda Conn, Upper House member, thank you also for your lived experience, your local experience and your political role now. I think you've given us perspectives as well as information that's really useful and is moving this debate along in a really powerful way. And Georgie Crozier, thank you representing your shadow portfolio role from the Victorian state perspective. Really clear insights and some passion to see this resolved. Very grateful for your contribution today. And of course, Dr. David Clancy, thank you so very much for your passion, your insights and your clarity of thought about what we need to do. Thank you very much. And thank you to our audience.
And Helen, thank you so much for facilitating such a wonderful discussion. So if the panel could go down, that is wonderful. Thank you. Thank you. And while the panel is finding their seats again, I did just want to recognise the fact that I know that we look for a seamless system. The New South Wales government and the Victorian government have what we call cross-border commissioners, and we have both of them here today. Both are relatively new to their positions. So we have Kalina Koloff, who's the New South Wales Cross-Border Commissioner, and Brett Davis, who's in day 3, I think, as the Victorian Cross-Border Commissioner. Very clearly, the governments of both states have identified over a period of time those issues that we see jammed in border communities. And in particular, I think through a process over a long period of time, whether it be natural disasters or COVID, or looking at things like health and other infrastructure, having people in government who can actually pull together groups of people to sort of develop a pathway forward is really, really important. So it's fabulous to have both of them here. They've been here listening to this, and getting them early in their appointments is also really good, because this issue then goes up the list on their agendas. I'm actually going to ask Matt Hyde to come up. Matt and the team at Wodonga have been furiously pulling together notes and starting to talk about actions, because very much the focus for this forum is talking about where to from here. It's not just about talk and listen. Listening, as we've heard from so many people today, is absolutely critically important, but we also need to start looking at what are the actions that we need to progress to the next steps. Matt.
Thank you. Thank you very much, Leanne. And firstly, can I say thank you? We have a really impressive list of attendees today, and we've heard some really compelling stories from our speakers. And our Albury Wodonga region community, thank you for assisting us in promoting a premier cross-border health regional service that is the best outside of Sydney and Melbourne. We've drafted up 9 matters for consideration today that have been prepared on the run, so my apologies if the wording's not spot on. So I'm just going to run through those 9 matters. We've listened very carefully to what has been said today, and hopefully these provide a wrap. So for the 2024 Albury Wodonga Regional Health Summit, ask that funding is allocated on a needs basis, catering for the growth of our communities, and recognising that early intervention to prevent people entering the acute care system provides the best return on investment. That the federal and state governments provide integration of pathways into health professions and Health Research Centre of Excellence to provide a vibrant future of collaboration and learning and create a location of aspiration for the health fraternity. That the state and federal government provide seed funding for the establishment of a collaborative education and research centre for rural and regional health, including operational resources and physical facilities. Through informed advocacy and concerted efforts, commit to uncovering and addressing key impediments that undermine collaborative healthcare and prevent professionals from working to their full scope of practice. Advocate for a return of the capacity data in the 2021 Clinical Services Plan and Master Plan as the servicing the current and future Albury Wodonga regional cross-border community, and make this a coordinated local approach where local leaders and subject matter experts are acknowledged for their local experience, and their contribution in co-designing the outcomes is paramount. Advocate to all levels of government to provide a regional governance model in order to have a one-system Albury Wodonga Regional Health Service that is appropriate for our community now and in the future. Make the Murray River invincible, I think were the words that we heard. Requests the Victorian and New South Wales Cross-Border Commissioners to establish a regional cross-governmental infrastructure and services coordinating committee to coordinate the provision of infrastructure and services beyond the hospital site, and to recognise the regional services catchment and operations. That the Victorian Government collaborate as a partner with the Federal and New South Wales Government and the Albury Wodonga regional community. That the attendees of the 2024 Albury Wodonga Health Summit thank all health workers and support staff that go above and beyond with the facilities they have to provide the best of healthcare to our regional community. Do you want to take some edits on that? Do you want to facilitate that?
So Matt and the team over here have been trying to feed through the amazing amount of input and discussion that's happened today. So one of the things that we're looking at getting any feedback in, is there anything there that stands out that is not a reflection on the group as a whole, or are there other things that we've missed? Susie? There's a microphone coming, which I think is...
There is an opportunity for you to make a commitment as a group and actually name the entities as a group moving forward to work as a group. And I was thinking with an independent
So for one of those asks is that as a result of this session, the summit, that the stakeholders around the table are named and commit to continuing to work together. And I'm also suggesting industries involved in that, and I'm not sure how many people here are community members, but because we do have a contract to increase health system literacy. And the committee that you move ahead with, and the reason I say a committee of all the stakeholders is because then it's not sitting with any one entity, where you sometimes have people taking over the whole session, and you employ an independent chair to run that, because this is a really, really important matter for you as a community. And I was thinking somebody like Fiona Nash would be excellent, because she understands the health system, she understands rural, but she also understands the politics. But, you know, that's just an example, but I think there needs to be a commitment from all the stakeholders.
Thank you, Susie. I think that's a good point, and I think it is about naming the people and working through that process. And an independent chair, I also think, is something that is being picked up in the notes that we're taking here. I have another feedback. Do you want to read that out while we're waiting for the microphone?
Yeah, Kelly, if we can just add into number 6 there. So it'll read, advocate to all levels of government to provide a regional governance model, and adding in with an independent chair and involving industry in order to have a one system Albury Wodonga regional health service that is appropriate. Industry and community? Yep. Thanks, Kelly.
Thank you.
John Scarce, Murrumbidgee Council. For number 5, probably comfortable with the 2021 clinical service plan, but from what I've heard about the master plan, it was calling for a greenfield site, a new site. We've already heard from Dr. Holland today the site's been set. So if that master plan's calling for a greenfield site and both governments are already committed to the existing Albury Hospital, then that's not the reflection of what's happening in this room.
We've got a microphone here, David, to respond to that. And I also think in terms of that process, we'll need to also maybe potentially get a response from Dr. Holland. David.
Again, please understand that the master plan that was drafted up looked at both options. So I think, again, when you look at how you set your funding and what you want to do, look at what is your endpoint and does it service the community, and that's why we need to go back to the service plan. And that's whether you put it on that site or not. You still need to really look at how you're doing it.
Dr. Holland, do you want to make a response, or we just get the feedback from the room? We'll just get the feedback from the room in relationship to that item, just by at the table's show of hands, people, if they're comfortable with that continuing in at this point as an outcome of this process. So around the room, just put them up so we can see them. We're not going to tie you down. Yeah, we'll work through the process, because this is not setting in stone the outcomes of this, but it is a picking up on some of the sentiments that have run through. John, again.
As I said, there's nothing. I think the room was fine with going back to the 2021 clinical service plan, but to set that master plan when it's clearly that the government is not going to go down that way, let's make the clinical service plan from 2021 fit and be funded to the future for the existing site that's there. No, not if we start going like this, we're going to just start stopping things, and we don't want to stop. We've already waited far, far too long.
We've got another hand up.
Thank you. The references to, sorry, Bruce Bolam from the Murray PHN. The references to the one system piece, I think, is excellent and very reflective of the discussions today. And there's a reference to prevention as well up in one of the earlier points. But I think there might be a separate point there around public health broadly and the integration from prevention, primary care, and into secondary care, as that is that one health system. And noting that both sides of the river now do have public health functions based within those health service environments,
So
which are clearly
it's
relevant
really,
to that.
you're saying tease that out
I think,
into
yeah.
another...
And just
into another.
maybe describing that one health system as going from prevention through to primary care, through to secondary care in an integrated way that reflects the needs of the community. As a necessary kind of underpinning of...
We're grabbing that down on the run, so absolutely we'll insert that as well, and I'll provide that feedback to Matt. Matt?
Sorry, was that I missed that?
Oh,
Kelly,
no,
did you capture that?
I've got that. We're going to put in an additional, rather than just the one system, as literally a different point under number 6, one that is moving to describe the one system, including the public health, the prevention, primary care. So really teasing that out a bit, or maybe making it a separate point, but you can fine-tune that.
Yep. Yep.
Any other points, questions, clarification? Any other things that aren't on that list that you as a group would like to see included or at least considered moving forward? Gotta love silence at lunchtime on a Friday, don't you, on the first day of autumn?
You can see if there's any real objection to anything that's there.
Yep. Now, the only objection or clarification that we're working through is the one that John has raised so far, which relates to the master plan and how that links to the clinical services plan, the 2021. Absolutely taken that on board. Are there any other key issues that people in the room have with any of these in terms of progressing to next steps? Because obviously a forum like this, and we've heard it a number of times today, is about moving to action. And we have a hand up over here.
Thank you. Thank you very much, Wodonga Council, for putting this on. Kylie, for Mayor of Albury. I really, that idea that was discussed and Helen mentioned, and also Jed as well, about National Cabinet and the role of National Cabinet. Is it worth an action somehow we get on the agenda of National Cabinet? And I'm not sure what that process is, but that would be a great ask if our federal leaders can do what they can. I know Helen does a great deal of work as an independent. We appreciate that, and hopefully Susan can do something from her end as well, and others.
That's a great point, and it would be good getting clarification. Helen, you probably are across this, but I know in some of the portfolios, I know local government, the two regional ministers actually have a get-together of the ministers of local government from around the nation. Does that happen in the health space, and would it be a good way to escalate in terms of that? Helen?
I'm going to say yes and yes. So yes, I will endeavour to get this on the National Cabinet agenda. I can't guarantee that will happen, but I'll do my best. I've been pressuring the Energy and Climate Change Minister a lot about getting some issues on the National Cabinet agenda from his portfolio, and I'm waiting to find out if I was successful when the news comes out later today. So I'll definitely commit to doing my utmost. I'll make representations to Minister Mark Butler and also to the Prime Minister on that. And in terms of local government, I might hand that one to Ron, because local government do have some say around national tables. So hand that one to you, Ron.
Thank you. Yeah, local government does have representation, but it's at a pretty high level and doesn't filter down to the run-of-the-mill councils all that well. Maybe I'll look into it and see where we can get. There might be an opportunity, particularly through the ALGA relationships. We might be able to find a way through it. Just going back to, well, I've got the microphone, sorry. Just going back to the master plan. The master plan of 2021 actually recommended a greenfield site. So to take that a step further, we've recognised with the information that's come out that we've really hit an impasse, and the likelihood of getting anything that remotely meets the needs of our community built, as has now been put in place by the two state governments, isn't the answer, and we do have to go back.
Thank you, Ron. We acknowledge the fact that there are two differing points of view in the room from various local government bodies, and we'll acknowledge that. But there has been a view put forward that go back to both of those, but actually acknowledge the fact that there is that's not a unanimous view of the room. And that will need to be resolved in clarification provided. And I think one of the things that we have picked up across the day today has been about the transparency in this. If decisions are made and things are non-negotiable by various parties, get them on the table so the community and the people working through that process understand. If you think it is all balls still up in the air, then you'll never get to resolving the best outcome. So there are sometimes in government and in other agencies situations where decisions are made and they're not negotiable until you get to a next election and things change. But be transparent and open and let the community know. So we will capture that, but thank you. If there are no other burning questions, comments, I did want to just do a wrap up quickly before I invite Ron up to close today's summit. I wanted to thank everybody. This issue really having been picked up and driven through local councils getting together throughout last year in responding to the needs and concerns of their communities across this region has been inspiring for me as a local government professional to actually see, health is not what we would classically see as something that sits in a local government remit. It's important, though, to our communities and that advocacy and leadership role from local councils. And this is the third session where you've had local government representatives, mayors and CEOs from across the region willing to get together and participate in this discussion in a respectful way, and I think that is absolutely outstanding. I also wanted to just note to the presenters and the panellists, this is very tough in terms of working through these sorts of discussions, and it's been done extremely professionally. The information has been presented in a way that's been easy for someone outside of the health system to understand what you've been talking about, but really people have been willing to put that forward, and the questions that people have put and the comments that have been made. And thank you to everybody who has participated across today in terms of being here and working through this process. It's another journey, another footstep that is taken in that journey, and it's going to continue to go on, and it is about that passion in a seamless community that is this border community moving forward. So well done to all of you. It's outstanding. I also really particularly wanted to thank Wodonga City Council and their staff that have actually taken up each of the times that there's been a forum, the couple last year, taken out the key points, put them to council and resolved to action the things that came out of people coming together. This forum is an example of one of those from a council report last year. And Matt and his team, Kelly and Lyndall and everybody have been fantastic at moving forward to see this achieved. So on behalf of those people around here, Matt, to you and your team, thank you very much. The role of local government in advocacy and putting things forward and continue on behalf of your communities is really important. And I think I go back to a comment that Helen, you made in the panel. We have a bold goal in terms of moving forward to really do the best that you can, because you get one shot at these things. So now's the time to be out there and working through that process. Ron, I'd like to ask you to come up and formally close the session. And we're not that late.
Thank you, Leanne, for doing all the work you've done today. Good job, well done. Today's been quite successful in a whole different range of ways, and I think we probably won't learn exactly what they all are until all these things unfold over time. Clearly, we've got a lot of work to do. Clearly, we've got some things that we have to convince government about, and I acknowledge that what that exactly is probably isn't uniformly accepted yet, but we do have to work through the whole process and identify where it all fits together. The speakers that we've had today have been absolutely extraordinary, and the information that's come out, the way things have been put together, the way we've learnt what it is that we need to be seeking to achieve is really good. It's strong. It makes a greater cohesiveness of our regional community. The bottom line of all this stuff is, if we don't work together, if we don't take the leadership roles, and if we don't get active, then we will get what we're given. So I commend everybody that's been participating in this today to try and take us forward and to get the outcomes we deserve. There's a couple of things. We've had an absolutely extraordinary job done by both the Cube staff that have organised the event today and put all the things in place, and by the staff within the council, the executive team and the events team that have worked really hard to put this together, and I think it's run really well. We didn't see any hitches or hiccups along the way, so I think it just shows that the background work has been extraordinary. So thank you very much to our staff. The other big thing is thank you very much to all the speakers and all the delegates and all the participants who've come and been part of this today. This may well not be the last time we actually have sessions of some nature like this. We've got a fair bit of work in front of us. Thank you to the gallery and those people that took the time to come out and participate, to be here to see what's happening. It indicates how important this is to our community, and I'm talking about our regional community. I guess that sort of sums it up. The only thing I've got left to say is everybody, including the gallery, is invited to stay and have some lunch with us. So thank you very much, and officially we'll close down and just let's get the talking done now over lunch. Thank you.
Thank you, Ron. And I have one last comment. Inside your program, there is a QR code. You know, when you get in the car and you start driving home and the light bulb goes off and you think, I should have said this or this needs to go across, there is an opportunity for you to continue or to pop anything else into that. So scan that wonderful QR code and make any further comments.